morning. If we can all find our seats, we're going to get started. My name is Donna Quinlan, and I'm the Program Director with the Colon Cancer Alliance. I wanted to thank you all for coming today to Conversations about Colorectal Cancer. We really appreciate you taking time out of your weekend, especially on Halloween, to be with us here today. For those of you who are not familiar with the Colon Cancer Alliance, I just wanted to briefly mention who we are and tell you a little bit about ourselves. The Colon Cancer Alliance is the largest and oldest national nonprofit for people affected by colorectal cancer. We've grown over the last 10 years from a small grassroots online support group to a national patient advocacy organization dedicated to ending the suffering caused by colorectal cancer. The Colon Cancer Alliance increases screening rates and survivorship by providing support and education and furthering research and advocacy efforts. Some of the Colon Cancer Alliance's signature programs include our toll-free helpline, our peer-to-peer buddy program, online colorectal cancer community called My CRC Connections, our Undy 5000 5K run and walk, and our Voices volunteer program. And lastly, the Conversations about Colorectal Cancer seminar tour, which you are participating in today. Conversations about Colorectal Cancer, Finding Hope in Your Community national tour was created out of a need expressed by colorectal cancer community members to help them better manage their own health care, connect with others, and give them access to the nation's experts. On behalf of the Colon Cancer Alliance, I hope you leave the seminar today with the information you were seeking and with the feeling that you're not alone. I'd like to take a final moment and introduce the other Colon Cancer Alliance staff that's here with me today. First, we have Jeannie Moore. She's our patient support manager and is also a caregiver. And we have Nancy Butterfield, who's a patient support advocate and as well a caregiver. Jeannie and Nancy happen to be California-based, and they answer the toll-free helpline. So if you have any questions about anything, you can call, and they're the ones that you're going to talk to. They also manage our online community that I mentioned, the My CRC Connections, so you can chat with them. I'm on there as well, but they pretty much handle that whole thing. And then Jeannie heads up our peer-to-peer buddy support program, so that's an opportunity she can tell you more about, or Nancy, if you have any questions about the organization, that they are here to help and answer those questions as well as I am. But they're in your community. I wanted to let you know that, whereas I'm from South Florida, I brought the lovely weather we had yesterday, I heard. Now I'd like to turn it over to Jerry Shields, the director of UCSF Helen Diller Family Comprehensive Cancer Center. The Colon Cancer Alliance is so thrilled to be able to partner with such a wonderful organization as UCF. Jerry.
Thank you, Donna.
Sorry.
Thank you, and it's really my pleasure on behalf of the UCSF Helen Diller Family Comprehensive Cancer Center to welcome you all here today for this seminar. I want to take a minute for a little bit of an advertorial. There are two things about UCSF that I'm particularly proud of. One is that we are what's called an NCI, National Cancer Institute designated comprehensive cancer center. Now, a lot of hospitals in the community name their programs comprehensive cancer centers to reflect the fact that they have a full range of clinical services in the area of cancer. The NCI designation is really intended to distinguish a different type of organization, and that's one that has an exceptional depth and breadth and quality of both clinical care services and research. We do basic science research as well as what's called translational and clinical research, and we are extremely proud of that designation. It's hard to earn. There are only 40 in the nation, and we're one of those. We're also proud to be part of what's called the National Comprehensive Cancer Network, and that's an affiliation of 21 of the leading cancer organizations in the country. Members from those organizations, physician members, come together on panels, and they develop guidelines for care around specific types of cancer. Those guidelines are published and used nationally and internationally as the standard of care. And because the science is constantly changing, those guidelines are continuously updated. One of our physicians who's here to speak to you today, Dr. Vanook, participates on one of those panels, the Colorectal Cancer panel. I also want to take a moment to thank Donna and her team and the Colon Cancer Alliance for not only their efforts broadly in supporting people with either cancer of the colon themselves or family members or friends, but also for their efforts to help us secure the funding to put this program on here today. And I would be remiss not to appreciate and recognize the staff and volunteers of our Cancer Resource Center, and in particular Naomi Hoffer, who's with us here today and who's put a lot of effort into making this happen. I also want, on behalf of myself and all of you, to thank our physician participants in this program who've given up part of their weekend. Drs. Wong and Kurlin, Dr. Vanook, and Dr. Varma. With that, I'd like to take 1 or 2 minutes to go through a little bit of a personal story, if you would indulge me on that. So this slide is a picture of a woman I see as incredibly energetic and vibrant and enthusiastic. And yes, this is my mom. This is a picture of my mom on the day we celebrated her 60th birthday by taking her out for her very first, and I might add, only, adventure in water skiing. If any of you have been water skiers, you'll know that when that boat, that motorboat, is pulling you up out of the water at accelerating speeds of 20, 30, 40 miles an hour, when and if you fall hard. It's like landing on concrete. Well, my mom didn't fall once. She fell at least 6 times, each one more painful to watch than the one before. But on the last, she actually got herself up to a near upright position. It lasted for a split second, but my brother was able to photograph her, got it on tape, and then, sure enough, she catapulted back into the lake. When she surfaced, she had 2 questions. Did I get all the way up? We said yes. Did you get a picture? We said yes. And she was done. But she had the most wonderful glow of satisfaction and pleasure in knowing that she achieved her goal and in knowing that we were able to capture it in film. Sadly, a couple of years later, she was diagnosed with a somewhat advanced stage of colon cancer, and it was devastating for the family. My father was married to her for 50 years. His heart was torn apart. My mom's sister, older sister, was devastated and convinced that this was the end of my mom's life. My aunt was on the East Coast. She literally packed her bags and came out because in her heart she knew that this was going to be the last time she could see her sister. So fast forward. This is my mom celebrating her 70th birthday, parasailing, also for the first and only time. But luckily this time she didn't land in the water. This is a little ironic in that my aunt never saw this picture or heard about this adventure because she actually passed away several years earlier. So it was my mom that carried on. Fast forward again, and this is another picture of my mom, this time several months after her 80th birthday. And I love this photo because it shows the same vibrant, energetic, enthusiastic, life-loving person that was in the photo 20 years earlier. And my mom's diagnosis was 25 years ago. So on the one hand, it sort of explains why her immediate peer group, her husband and family, brothers and sisters, saw this as a death sentence. But for my mom, it was a little bit more of an interruption in her life. And I swear, she never looked back. Was she lucky? You bet she was lucky. Was she also a recipient of some of the advances in science and medicine that were beginning to take traction then? Absolutely. Is cancer still a threat today? You know it, I know it. But have the advances continued? They certainly have. And they continue today. The contributions of people, physicians and scientists like the 4 that you will hear from today, are really made from the heart. I work with these individuals and they commit their lives and their energy, their creative thinking, and their brain power to making advances that we'll all benefit from. So with that segue, I'd like to hand the podium over to Naomi to introduce our first speakers. Thank you and welcome.
Thank you so much, Jerry, for that lovely welcome and introduction. Hi, everyone. My name is Naomi Hoffer. I am a program manager at the Ida and Joseph Friend Cancer Resource Center. I am very happy to see you all here. For those of you who don't know about the Cancer Resource Center, we are located here right directly below this auditorium on the first floor, and our mission is to serve persons with cancer through a number of different free wellness programs as well as services and events such as this one. So if you're not already on our mailing list, I invite you to visit the table that we have out there and put your name down so you can be a part of our mailing list and you can learn more about events such as this as well as other events that we have every month. So now, for the reason you're all here, I'd like to go ahead and introduce our speaker. And one thing I'd like to say is please respect the fact that this is not a forum to give personal medical information. Our doctors are here to share their knowledge with you, but they're not able to answer personal medical questions. So I just want to emphasize that. I am very pleased and very honored to introduce our first speaker for this morning, Dr. Helen. Dr. Vanook is a nationally renowned expert in colorectal and liver cancers and leads the gastrointestinal oncology clinical program here at UCSF. He is also a professor of clinical medicine at UCSF and is the director of the UCSF Cancer Center Clinical Research Office at the Mount Zion site. His research focuses on treating liver tumors with directed approaches, including infusional chemotherapy or biological agents, and he has published extensively in this field. Dr. Vanook graduated from the UCSF School of Medicine in 1980. He spent 2 years in the Public Health Service following internship and trained in internal medicine at UC Davis and in hematology and oncology here at UCSF. He has been on the medical staff here at UCSF since 1988. Please help me, if you will, in giving a very warm and appreciative welcome to Dr. Helen Vanook.
Well, I thank you for that kind introduction. I didn't realize I was that old, but well, welcome. I see a lot of faces I recognize, and actually had the distinct pleasure of a patient, one of you in the audience, coming up to me and reintroducing himself 15 years after we treated him for stage 4 colon cancer. And in my business, when I lose track of people, well, what do I assume happened? And it was obviously great to see this patient here. I don't have slides. Trust me, I have lots of slides I could use. But what I wanted to do was talk about individualizing therapy and take you through sort of how we approach colon cancer in this day compared to what we did way back when I started in this field. And to do that, I thought I'd sort of throw out some numbers and then discard the numbers. And I think the most important message for patients with cancer, as Jerry described in her poignant vignette about her mother, is that as oncologists and as physicians, we make decisions based on statistics. We have to have a counterbalance between risks and benefits and make decisions of how to treat patients based on the literature, based on studies. So we need to really understand statistics. But everybody individually is not a statistic. And so when we make decisions or when we look at the literature, we balance the statistics, but each patient is their own patient. And I emphasize that because the internet giveth and it taketh away. And I think there's a proliferation of information that patients are armed with, that you have access to. And it's all driven by statistics. And my rule of thumb is that statistics, of course, mean are averages. Some patients do better than average. Some don't do as well as average. I teach our fellows to assume that every patient will do much better than the average until proven otherwise. And that's very important to recognize. So I will stay away from statistics because they're really not, they don't apply to the individual patient, although obviously they have effect on how we make decisions. What I wanted to talk about is the way colon cancer has evolved over my career. Again, I'll use the example of the patient who reintroduced himself to me today. 20 years ago, to give you an idea, and I will throw some statistics out just to give you the breadth of the difference. 20 years ago, about 35% of patients with colon cancer were cured. That's of all comers. That's independent of what stage they were found. So your mother was the exception to the rule. Today we cure well more patients with colon cancer than we fail to cure. Some of that is screening, and if you remember nothing else from today, it's that if you are a colon cancer survivor or living with colon cancer, your siblings, your parents, your children may be at risk. There's a familial risk that's very clearly passed from generation to generation. So some of this is screening and finding earlier stage disease, but much of it is understanding the disease better and figuring out how to treat patients as individuals to make decisions more wisely than we used to. And the other big difference is that 20 years ago, we really never cured a patient with advanced colon cancer, a patient whose cancer was stage 4. As an oncologist, it's inevitable when last night, for example, I was at a function and people sort of hone in on me and to ask me questions, and the question that people always ask is it stage 4? Well, stage 4 is advanced disease, but colon cancer is a disease that we cure, even in stage 4 at times. So this is about, what I want to talk about is how we've evolved and how we've learned to make individualized decisions. One of the buzzwords in cancer care is personalized medicine. That's a buzzword in all fields of medicine. And the idea is individualizing therapy, is recognizing that diseases are heterogeneous, that how we treat one patient or another may be quite different based on their individual characteristics. And what I'm going to talk a little bit about is how colon cancer has evolved to the point where a patient now can come into the office and rather than empirically applying the standard therapy, we can start to think about individualizing treatment and making wiser decisions. That allows us to avoid ineffective treatments, focus on effective treatments, and after all, that's the way we would optimize our results. I will make a plug. Some of what I'll talk about is research we've done here at UCSF. Many of you here in this auditorium have contributed to that, to some of the research, insofar as the critical aspects of research are tissue acquisition. So within the cancer center, we keep tumor tissue, and we analyze it. And really the way we move the field forward is by, as Jerry talked about, translational research. You take tumor tissue, you take the genetic features of a patient, you figure out how the patient did, and you try to correlate it with genetic markers, for example, and that gives us insight into how to best manage patients. I'd also mention that today's patients are contributing to our knowledge tomorrow, and that's I think I would say, as I've said often, when people ask me how I do what I do, it's interesting, and I feel like I can make a difference. But I see patients who have more courage in any given day than you would think people can generate. And these are patients who many times are giving to the future generation of patients, not just to today's patients, and often not for themselves. So what I wanted to talk about was sort of how the field has evolved, and to give you a couple of numbers. First of all, the good thing is the incidence of colon cancer is decreasing. Colorectal cancer, there are fewer cases this year than there were last year than there were the year before. And why would that be? Screening. Now, the one point about screening is any takers on what percentage of people are getting the appropriate screening tests that are recommended? 40% is the operative figure, and we were talking out in the lobby. Why is that? It's like it's a taboo subject, the colon and the rectum. Bob Dole can get up and talk about sexual dysfunction from his prostate cancer and advertise Viagra, and yet we can't talk about colorectal cancer screening. So Ernie Rosenbaum, who's one of the gentlemen, the giants here at UCSF as a longtime oncologist, has made that his main interest, which is trying to get people to accept screening. But the incidence is going down, and in fact, colon cancer is being cured. Even as the incidence goes down, we're curing more and more people. If you find the disease earlier, we cure patients. But even so, about 2/3 of the time, the cancer is beyond the reach of just doing surgery. And the critical differences have been, believe it or not, chemotherapy. Now, any patient who's had colon cancer in the last couple of decades would have had 5-FU. And in fact, there may be some of you in the audience here today who were cured of colon cancer just with 5-FU. And the rationale of chemotherapy in a disease like colon cancer, surgery is the mainstay of treatment, and you'll hear from Dr. Varma. But the concept is that these cancers have been there a long time and have had a lot of opportunity to spread. The working hypothesis for colon cancer, any takers on how long it takes a polyp to turn into a cancer? 3 to 8 years and that's through elegant research on following the rate of polyp formation. So over that time frame, you have every opportunity for cancer cells to get access to the bloodstream and then land in another organ. People with colon cancer die from spread of cancer, metastases, rather than from the local disease. Occasionally there'll be a patient who dies from an obstructed bowel, but really it's because it spreads. And so the role of chemotherapy back in the 80s first became clear that you could eradicate microscopic disease. So a patient has the cancer removed, the surgeon says, "We've got it all, dear," and then you realize that the cancer may have spread in the bloodstream. And the use of chemotherapy in some patients early on could eradicate cells and cure patients who wouldn't have otherwise been cured. Now, we owe a debt to the people who participated in the original studies. The original studies in colon cancer took patients with colon cancer and randomly assigned them to no treatment or chemotherapy. Now, how many of you, if your colon cancer, if you had colon cancer, just as this is the U.S. experience, how many of you would be willing to have no treatment in a randomized study? I don't see any hands, and it's pretty bold that 20 years ago there were people willing to do that. Nowadays, we know that because of the willingness of those patients, we know that 5-FU helped some patients. And we went through the 90s, in fact, without anything other than 5-FU. We spent a lot of time trying to slice and dice and figure out how best to manage patients. We, for example, here at UCSF did a lot of research on chemotherapy directly into the liver, when we realized that a subset of patients with colon cancer have a spread into the liver, but nowhere else. Now, why would that be? And I'll talk a little bit about the research that's been done since. But the real change over the last decade has been the proliferation of new drugs. And to that we owe a debt of gratitude to capitalism and the pharmaceutical industry. Because, in fact, without the pharmaceutical industry, we wouldn't be where we are today. And we've had the introduction of a number of drugs, a drug called oxaliplatin, a drug called irinotecan, a drug called capecitabine, which is also known as Xeloda, and then drugs like Avastin, Erbitux. Erbitux is a drug that put Martha Stewart in jail, and Vectibix. So we've gone in the last decade from having one drug to having a host of drugs, and there's no question but that between screening, awareness, improved surgical technique that Dr. Varma will talk about, radiation in selected patients with rectal cancer, and all of these, we've just changed the face of the disease. So it's to the point now where, as an oncologist, when I see a new patient with colon cancer, and we see here at UCSF many patients with colon cancer. I think I saw 8 new patients with colon cancer this week at various stages. The first question we ask is, can we cure this patient? And that's a change in the paradigm, because a patient with advanced disease you used to just concede that the disease was incurable. Now we first ask the question, can we cure the disease? And then we ask the question, and what we believe we're doing more and more of is, can we turn it into a chronic disease, if not a curable disease? And I don't say that lightly. Any of you who've been in the office, in the exam room with me, and had me talk and counsel you as an oncologist, I'm honest. I teach the fellows that it's easier to tell the truth and remember what lies you've told patients, and I think we owe it to our patients to be honest. And yet I really am honest by saying goal of cure is sincere in many patients, and turning the disease into a chronic disease is not a pipe dream. And I know a few of you in the audience heard the cure word for the first time from me after the diagnosis. And again, this is not a fabrication. This is just the fact that we move forward in how to manage the disease. So how do we manage the disease? And a lot of this is gray area. One of the things that I would emphasize is that in advocacy groups on the internet, there's a proliferation of literature in support groups. A common question I'll hear is, Mrs. Jones in the support group got such and such a therapy. Why am I not getting such and such a therapy? And hopefully there's a good reason. Maybe not. But the point is, everybody would be managed individually. And so how you deploy chemotherapy is beyond the scope of what I'll talk about today. How you choose the chemotherapies. But what I want to talk about is how we make decisions, and how it's evolving. So with any cancer, we stage the disease, and Dr. Varma, the colorectal surgeon, is the critical component of how we stage the disease, because we need to know one component of the question is, are there lymph nodes involved, and has it spread? And you really usually don't know what the lymph nodes are until the pathology department is analyzing them. And you don't know if the disease is spread until you've done scans and the sort of imaging things that we do. So we need surgery really as the kingpin of how we approach the disease. And while there's interest in avoiding surgery, giving Dr. Varma a little bit of time out of the operating room, in fact, that's not on our radar screen. We cure patients with these diseases. We treat patients with these diseases with surgery. But what we really need to know are nodal status and whether disease is spread. Now, lymph node involvement is a biological commentary on cancer. It's not that people succumb to cancer because it involves the lymph nodes. What it reflects is that the cancer cell, which originated in the tumor in the colon, has the capacity to get in the bloodstream and settle at another location. In fact, that's the critical question of how patients die and how a cancer spreads. It metastasizes. If we look, we can find circulating cancer cells in almost every cancer patient. So even patients who have been cured 20 years ago with breast cancer you can find cancer cells in the circulation, but they don't have the capacity to go to another organ and grow and become tumors. And so the lymph nodes are not, it's not that the cancer spreads from the lymph node to the rest of the body, it's that it's in the bloodstream, it settles in the lymph node, which is close by, and that is a biological commentary on how the disease, what the capacity the disease has. And that's why patients who have no lymph nodes have a much better, no lymph nodes involved, have a much better chance of being cured than patients who have lymph nodes involved. It's a biological comment on the cancer. Now, of course, some patients, unfortunately, the cancer has spread by the time we find it. That's called synchronous disease. And we know that the cancer has the capacity to spread, and then it's a matter of figuring out where it spread and how we can get at it and can we eradicate it. So staging is critical, and the decisions that medical oncologists make after the surgeon has operated is there a role for subsequent therapy? And again, this is very individualized, but I want to give you an example of how we're learning to make this decision, and then I'll give you a couple of examples of the modern era. So if a patient has no involved lymph nodes with colon cancer, studies show that there's an 80% likelihood that the cancer won't return. So 4 out of 5 patients are cured if you do nothing else. Now there's studies that have been done that the sum of the data suggests if you do chemotherapy with the risk, you have about an 81% chance of being cured. So that means that you would treat 100 patients to cure 1 patient. 19 patients died of their cancer anyway, and 80 were already cured. And if you look at as an oncologist, the calculation, of course, is what's the downside to this 1%? The risk of dying of chemotherapy, even when we give it here at UCSF, and we've got great personnel, great nurses, a great meticulous attention to detail. It doesn't matter how well you do it, about 0.5 to 1% of people die from chemotherapy. That's 1 out of 200 patients just have severe toxicities. So you can imagine the debate, is it worth doing chemotherapy for a 1% advantage if the risk of dying is almost the same? And I'm not sure that anybody would opt for that, although interestingly enough, in the breast cancer world, many women would opt for those numbers. I probably wouldn't opt for those numbers myself. This is sort of where the state of the field is, but the question is, can't we figure out who the 20% are and make an impact in that 20%? And instead of adding a 1% increment, can we figure out, and we now know that this 80%, if you look at survival curves, is made up of a group who do really well and a group who don't do so well. So can we slice up this subset of these patients and figure out who's going to do well and who won't? The answer appears to be yes, and this is the result of research, and it's got to do with the genetic signature, the genetics of the cancer. Cancer is a genetic disease insofar as many patients have a predisposition genetically to developing cancer, but cancers evolve as genetic mutations occur. So a polyp starts out as just an extra growth of normal tissue, but as the cells multiply, the DNA gets screwed up from one multiplication to the other. Those are called mutations. One mutation may lead to a little extra growth, and then the cells that are mutated are predisposed to mutating again and again and again. And so you get genetic mutations not in that you pass on to your kids, but genetic mutations within these cells that lead to cancer forming. And we now know, it appears at least that we know, that there are distinct genetic mutations that we can analyze, and the main one is called MSI. There's also deletion in 18q, and there's actually a couple of tests, one called Oncotype DX colon, which can analyze the molecular features of a cancer and more or less tell people what their relative risk of relapse is, not rather than saying you've got an 80% versus 81%, perhaps identifying the patients at the greatest risk who would be best treated with chemotherapy. Now, that's huge because it allows us to make wise decisions. It spares patients treatment who don't need treatment and can focus our energy on patients who may need treatment. And this is evolving, but again, how did we figure this out? It's by research on tumor tissue, looking back at how patients have done, and then moving forward and applying the lessons as in prospective fashion. So that's the role. That's one way the field is evolving. The other evolution, we have better chemotherapy. So today's chemotherapy cures patients that we didn't used to cure, and the big advance in that regard is a drug called oxaliplatin. It's called FOLFOX is the combination, so we know that that's valuable, but what we'd like to know is, should we treat patients with FOLFOX or not? Anybody who's had FOLFOX, unfortunately, may be able to attest to the side effects of FOLFOX, which is neuropathy, numbness and tingling in the hands and feet, and you'd like to spare patients that. So we believe that the genetics of the cancer will ultimately lead us to distinguish who needs FOLFOX and who does not. The other advance is less dramatic, but also consistent with the theme of personalized medicine, and that's the advance in what's called the KRAS test. And this is really an incremental step, but it's an assurance that we're moving to the point of being smarter, of treating advanced patients as well as early stage patients. And I'll just say a word about what this is. KRAS is a mutation. Again, as cells divide, the DNA changes, and there are particular genes that are especially vulnerable to mutation, and one of them is the KRAS gene. KRAS is the kind of discovery that led to UCSF people, Harold Varmus and Michael Bishop, winning the Nobel Prize 20 years ago for discovering that these genes there were a predictable number of genes that would be mutated in cancer. What we learned is that with a class of drugs called the EGFR antibodies, Erbitux and Vectibix, these are used in conjunction with chemotherapy. Patients who have a mutation in the KRAS gene do not benefit from those drugs. And so while we'd like to have a genetic marker that tells us who will benefit, it's also of value to tell us who won't benefit. And so you can spare patients a treatment with a medication that has a lot of side effects by analyzing this test. So the current paradigm, as opposed to having a patient who just comes into our office with stage 4 colon cancer with metastases, the current paradigm is not just let's guess and let's do chemotherapy, but it's trying to narrow the field of what the valuable therapies will be. Now, what we need to go further on is figuring out who we cure and who we can't cure, and how do we go about doing that. And this is an extension of this paradigm. Now, one of the critical issues, as you can see, is there are a lot of moving parts in these decisions. I see I'm going to get the hook in a minute. So she's getting ready with the red one. Let's see. 1 minute with an exclamation point. What I would and we'll talk at the end, and you'll hear a lot more about the various aspects. The one final message is a bit of advertisement with Jerry's permission, and that is that these are not easy decisions. And one of the things that you'll hear today is a lot of expertise in one room, and you'll also realize that different centers have different levels of specialization. So one of the advertisements, and one of the ways we learned all of this and can incorporate this, is that there's there is value to going to centers where there's a focused interest in this disease. We know, for example, that colorectal surgery is, the outcome for patients with colon cancer is better when a colorectal surgeon does it than a general surgeon. We also know that to be the case for many other cancers. Here at UCSF, we have a research group, we have integrated practice, and what I'd say the big difference is, I, for example, do mostly colon cancer and liver cancer, and that's what I do. If you have breast cancer, I'm not your guy. I don't know much at all about breast cancer. There are other people who know a lot more. And I think that's one of the take-home messages is this is a unique disease in every patient, and it takes experience and multidisciplinary expertise to figure out how to best manage patients. So I'll stop there. I think I'm not allowed to see if there are any questions. And I'll yield from there.
Thank you so much. So I'm very delighted to introduce our second speaker for this morning. Dr. Kim Hwang received her Doctor of Medicine degree from the University of Pennsylvania School of Medicine. She completed her internship at St. Mary's Hospital in San Francisco and her residency in radiation oncology here at UCSF, staying on as faculty. Dr. Hwang specializes in radiation oncology with a particular expertise in performing cyberknife radiosurgery. She is also interested in using other radiotherapy techniques and devices such as intensity-modulated radiotherapy, intraoperative radiotherapy, gamma knife, and proton beam radiotherapy to treat a variety of malignant and benign conditions. Please help me right now in welcoming Dr. Kim Hwang.
Thank you very much for the nice introduction. I'm very glad to be here. So I'm going to talk about advances in radiation oncology, in particular relevance in colorectal cancer. So as you already heard from Dr. Vanuk, treatment for colorectal cancer is a multidisciplinary approach with a combination of therapies, surgery, chemotherapy, radiation, and other local ablative therapies like RFA you'll hear about later today. And so chemotherapy is different from the other approaches. Chemotherapy is systemic therapy. We talk about the rationale why, and because of the microscopic cancer cells, even when patients are detected with relatively early stage cancer, there could be cancer cells already spread. So a lot of times patients come to me for radiation. The radiation therapy is not alternative to chemotherapy. Sometimes patients say, well, if I have radiation, maybe I can skip chemotherapy. So radiation, like surgery and IFA and other approaches, are local therapy. So we affect the area we treat, and we only treat certain parts of the body to try to aim at the cancer and to try to decrease the chance of coming back. In our field, we call it local control. We try to control the tumor where we aim at. So radiation therapy, sometimes patients hear about it and they get scared. They thought of radiation and other hazards that can happen. It's basically a high energy X-ray, so like traditional X-ray, like a plain X-ray or CT scan. They are kV energy, so that in the kilovoltage energy range. For the therapeutic radiation, it's in the megavoltage range, so it's really much higher energy. And before the routine use of CT-based planning, the treatment is called 2D planning, two-dimensional. So usually radiation is, in the old days, was relatively simple with one or two radiation beams, usually aiming at one direction or opposed. So in this case, let's say this is a patient with rectal cancer who needs who has locally advanced disease, needs radiation to the pelvic region, and the radiation is coming from the front and back. And you can see all the tissues within the field, front and back. It's getting treated through and through. It's not with not much sparing of the other normal tissue. So with the advent of a CT scan, and then in the early 90s, with advance of mainly computer power, CT-based planning become the standard treatment everywhere now. So the two-dimensional treatment planning, usually patients get what's called simulation, and it's a conventional X-ray machine and with a fluoroscopy capacity, and the geometry of the X-ray machine, the simulator is the same as the treatment machine. So we map out the area first on the X-ray machine, and then and put marks on the patient, and then we go ahead to put patient on the treatment machine to deliver the radiation. And with 3D treatment planning, a patient get a CT scan, and we can draw the tumor on the CT scan, and based on how the tumor looks, multiple radiation beam can be directed at the tumor. So with 3D conformal radiotherapy, that's what's called. It's multiple shaped beams coming from multiple directions to try to treat the target. So in the case of rectal cancer, when we treat the pelvic area, the areas at risk include the primary cancer, the tumor bed, if patient already has surgery, and the lymph node region. So usually it's coming from 4 different directions. It's called a 4-field box. So you can see the dose, the high dose region basically is a rectangle, if you see. So comparing the 2D versus 3D, you can already see there's advantage. The top panel is the 2D treatment with just a radiation beam coming from the front and back, and the 3D is the 4-field technique. Because you need to treat the rectum, which is the posterior structure, and the lymph nodes. The tissue you really spare is in the anterior and superior corner, which is where the small bowel is. You can decrease the dose to the bowel, to the small bowel, and decrease the side effects such as diarrhea for patients who had radiation. Usually they have chemotherapy concurrently, which can also contribute to diarrhea. The decreasing side effects can make the treatment more tolerable, and a patient can go through the treatment without any interruption. So this is a schematic of the conventional radiotherapy with 3D techniques. The tumor shape, unfortunately, is not always a square or a round ball, and it can be irregular in shape. With the conventional technique, you can have 4 beams. You can have more, 7 or 8 different beams, but within each beam, the intensity of the radiation is homogeneous. So the end result, when you put these beams together, you can design with different angles. The dose distribution, which is shown on the right-hand side, is like in this case it's a rectangle. Usually it's convex shaped. It could be more rounded with rounded edge if you have multiple beam distributions, but you cannot conform to the shape of the tumor. If it's irregular with a concave shape. But with RMRT, intensity modulated radiotherapy, each beam, across each beam, the intensity can be different. And when you add up with multiple angles, you can deliver high dose to the radiation, to the tumor region, and the dose can drop off from high to low when it gets to normal tissue. So it shapes around the tumor better. So we call it's more conformal to the tumor. So this is an example. It's actually a brain tumor treatment, but from one angle, you can have multiple segments with irregularly shaped beam, and the composite of the of the multiple segments, or create a intensity map, which is shown on the left-hand corner, lower corner. You can see so the whole entire radiation field is divided into 1 centimeter squares, and they're each voxels, and within each square, the intensity can be different, and the end result will be better shaped radiation around the target. So this is showing example of pelvic radiation. On the left-hand side is the 3D conformal therapy with a 4-field box. You get the rectangle-shaped radiation beam. And then on the right-hand side is IMRT. The purple is what we draw on the computer and include the lymph node region and also the posterior rectal and the area that we want to cover. So it's like a V-shaped, and you can see the green line, which is a prescription the acidosis line that covers the tumor. It shaped around the target much better, and it spares the tissue in the middle, which is the bowel again. So patients who have IMRT for their pelvic treatment, they have much less toxicity, such as diarrhea, and we also spare the pelvic bone a lot better with IMRT, so they'll have less problem with blood counts. Radiation does affect blood count if it treats bones with a large amount of bone marrow, such as the pelvic bones. So a lot of patients are curious about tomotherapy. What is it? It looks like a CT scanner. So with the CT scanner, we talk about the source is a KV X-ray. Instead of the KV X-ray, the tomotherapy machine has a MV X-ray source. So it's like the therapeutic radiation machine. It can give therapeutic radiation, and the patient goes through the machine like when they get a CT scanner, and so the end result is there are multiple segments of shaped radiation directed at the target, and it's a form of IMRT. And I'm going to talk about this one more level of sophistication on top of IMRT, which is IGRT. With the tomotherapy, like a CT scanner, you can scan the patient before the treatment and make sure patient's lined up. So we do that with conventional treatment, but there's so first of all, there's a different level of precision when you do the lining up, whether it's within a few millimeter or within less than 1 millimeter. That makes a difference depending on where you treat. And also, we're treating living patients, and their organ moves, and we can, if a lot of times we put in what's called fiducials, which is gold marker seeds in the tissue or in the tumor as a surrogate for how the tumor moves, and we can align the patient better, not just based on the bony anatomy, but based on the internal organs and tumor. So the tomotherapy, in the gist is a CT guided IMRT, so it can do IMRT and IGRT, which I'll talk about. So we heard about heart surgery is a big component of treating colorectal cancer, and so for patients who had locally advanced rectal cancer, or in particular recurrent rectal cancer who's already had prior radiation, we tell patients with the traditional radiation, generally it's called external beam radiation, whether it's 3D conformal or IMRT. It can be only done once to the same area, because your body has a certain tolerance. So each tissue has different sensitivity to radiation and has certain limit of radiation we can give. So usually, once we treat the pelvis once, we cannot do it again. But the intraoperative radiation therapy, it uses electron beam, which is different from the X-rays are photons, and the IRT machine develops electron beam. It's good at treating superficial tumors such as skin tumors, and in this case with IRT, the surgeon like Dr. Varma will prefer the surgery, remove the tumor, but there's concern that the tumor may be stuck to certain areas and there's microscopic disease left behind in the surgical bed. And we can direct the radiation directly into the surgical bed and give a high dose radiation right there during the surgery. The advantage is you can remove the normal tissue such as the small bowel, which is sensitive to radiation, and any tissue you're concerned about away from the radiation, and you only aim at the area that you're concerned about. So UCSF actually is one of the first place that got the IRT machine, and we do a lot of cases with the surgeons, working with the surgeons together. So this is a picture. So the patient is on the table, and then surgery has been performed, and the wound is open, and we have a comb directed into the area of surgery and deliver the radiation. It adds another 30 minutes to an hour to the procedure. Sometimes there's some technical issues, can take longer, but it works very well, and we really like the advantage of giving additional radiation without causing problems. I think the other request from the audience is about brachytherapy. So the brachytherapy is basically a short-range radiation, usually delivered through radioisotope, and nowadays usually it's delivered with high-dose ray brachytherapy, which uses iridium-192 source, and the source is temporary. Basically, the source will go to the position you specify and stay there for a few minutes, and then withdraw and deliver the dose there. So, in the case of rectal cancer, it was pioneered by the French, and in the initial report there were some toxicities reported. So it's not widely used in the United States, but this report is from Canada, and they are using it. The advantage is you can give additional radiation to the rectal tumor on top of the pelvic radiation, for example. So it requires a probe that's put in through the rectum, and then you can you can do a CT scan and outline the area, and you design the radiation where you want to stop and how long it's going to stop, and then then the computer controls the source to go into the specified area. With these treatment, it's very technique dependent. So, you have to go to centers with really the specialty and the experience in performing it to have it done. And this is not in replace of surgery or chemotherapy. Occasionally, patients who are not able to have surgery, potentially you could, with this treatment, you could try to eradicate the tumor in the rectum, but generally surgery is still required. Okay, so the IGRT is image-guided radiotherapy. So on top of the IMRT, which is kind of the most sophisticated external beam technique, image guidance so provides additional precision, so you can aim at the target more precisely, and if you can do it more precisely, then you can minimize the margin. So we add a fudge factor because the patient can move and the tumor can move to make sure we are aiming at the tumor, and if you can be really precise, then the margin can be really reduced and you're only treating the tumor and you can protect the normal tissue. So the therapeutic advantage in radiation is to try to maximize the dose to the tumor and protect the normal tissue around it. So there's different kind of machines that can do this. So the traditional radiation machine, you can add a KV source, and then you can do plain KV X-rays, or if you take the pictures as you rotate the gantry, you can get what's called cone beam CT. So it's a form of CT with 3-dimensional images, and so this is usually done before the treatment, and then the physician will make sure the patient is lined up correctly, and then you deliver the radiation. And on the right top panel is the Novalis system. There are 2 X-ray images mounted on the ceiling. It takes pictures, and then the computer will figure out the displacement in terms of in the XYZ direction, in the translational direction, and also rotational direction. And the tomotherapy we talked about, it's a NVCT scanner. Basically, you do a CT scan and then you line up the patient. And the last one is the CyberKnife machine, which is a little different from the others, but the general concept is the same. There are two X-ray cameras mounted on the ceiling, and the CyberKnife machine is a miniaturized radiation machine. So just a word on proton beam. It's gaining a lot of attention lately, and it's becoming more widely available. A lot of centers are getting it. So the advantage of proton beam is the dose distribution. There's what's called Bragg peak, and the dose will build up as you get close to certain depths, and then it goes high dose, and then the dose drop off sharply. So the advantage will be to treat something close to the critical structure, and you can really minimize the dose at the normal tissue, which is right next to the tumor. And there are various comparisons of proton beams with RMRT, the stereotactic radiotherapy, which is just basically adds another component of precision. Generally, the high dose area, you can achieve similar dose distribution. The difference for proton beams generally is in the low dose area. So there's still debate in the field what's the utility of proton beam, whether it provides benefit for certain patients, and this needs to be worked out because the proton beam obviously is very expensive. Okay, so moving on. So this is an area of my interest, which is radiosurgery. The radiosurgery basically delivers a focused radiation, high dose, and we direct radiation to the tumor, and the dose go from high to low very quickly. There's a sharp dose drop-off. With the gamma knife, this is the older model of gamma knife. There were 201 radiation sources and focused on the one spot. So you put the focal spot right in the tumor, so the tumor gets an extremely high dose. But if you move away from the focal spot, you only get 1 out of 201 fraction of the contribution from the source, and the dose goes to relatively low. So we have the newest model, which is a Perfection at UCSF, and it's fully automated and makes the treatment faster, and it works really well for patients with brain tumor. So they will need a stereotactic frame placed with screws in the skull and with local anesthetics. So there's no knife involved. It's basically delivering the radiation. And after the stereotactic frame is placed, they get imaging, and then we plan on the computer and deliver the treatment. This is done in the same day. So gamma knife can be used in brain tumors, benign, malignant, as well as other type of benign conditions. So we treated thousands of patients with gamma knife. Most of the patients had brain metastasis. This is an example of the gamma knife treatment. So the yellow line encompasses the tumor, which is the prescription dose, and the green line is half of the dose. So you can see it drops off very quickly. This is really a zoom up view. So it's the majority of normal brain get minimum dose. So because of success of gamma knife and the traditional radiation machine, the linear accelerator can be adapted to perform gamma knife kind of treatment with radiosurgery. And because of success in the brain, people started using it in the body. And CyberKnife was first invented by a neurosurgeon at Stanford to compete with the gamma knife to treat brain tumor patients. And the CyberKnife, it turns out, it's more versatile and can treat anywhere in the body. So this is LINAC-based stereotactic body radiotherapy because the tumor moves, especially the tumor in the liver and lung, it moves with breathing, and there's a special device that can minimize the motion of the tumor. And this is the CyberKnife. It's a small linear accelerator mounted on the robotic arm, and the robot goes in different points in space and aim from multiple different directions. and the X-ray camera take pictures periodically to make sure patient is still aligned, and it's all done with computer-controlled automated approach. So this is our current CyberKnife machine. We're getting a new model early next year. So this is the so the robot goes to different points in space, and at each point that you can have different directions of the radiation beam. So in theory, you can have over 1,000 radiation beams. And usually, for a particular treatment, we use like 200 to 300 radiation beams to cover the tumor target. So in order to be precise, there are different modes of tracking. For brain, you can track the skull, and for soft tissue, we use fiducial tracking, which is the gold seeds. We talk about. So these are the gold seeds, and I usually ask Dr. Curlin and his colleagues to help me put it in the patient. And, so Synchrony is a special system unique to CyberKnife. Patient wear a vest, and on the vest there are light-emitting diodes, and this camera detecting the light-emitting diodes, and so you can monitor patient's breathing. At the same time, you take X-ray pictures to line up the patient, and then computer builds a model based on how the patient is breathing. This was supposed to be a video, but it doesn't work. Basically, you will see the head of the machine will move with the patient as the patient's chest goes up and down. The machine will go up and down with the patient. So CyberKnife can treat brain tumor, spine tumor, and lung and liver, basically anywhere in the body. And we have treated many patients over the years since 2003. And the top number of patients we treated are patients with brain tumor, lung tumor, and spine tumor. So I'm just going to give a couple examples. This is a patient. She's a 90-year-old woman with colon cancer, had surgery and chemotherapy, did fine, but she has this liver metastasis, and so we treated her with CyberKnife, and the PET scan showed the metabolic activity of the tumor disappeared after treatment. She's still doing well a year after the CyberKnife. And this is the patient with lung metastasis. We can do a similar thing with patients with limited metastasis to the lung. So
I am very pleased to have our next speaker with us today. Dr. Madhulika Varma is the Chief of Colorectal Surgery and an Associate Professor of Surgery at UCSF. She specializes in the surgical treatment of diseases of the colon, rectum, and anus. She is a specialist in advanced laparoscopic and robotic colorectal surgery using minimally invasive techniques to treat many of these diseases. Dr. Varma is also the director of the UCSF Center for Pelvic Physiology and is a member of the clinical team of the UCSF Women's Continence Center and the UCSF Center for Colitis and Crohn's Disease. Dr. Varma earned her medical degree at Brown University School of Medicine in Providence, Rhode Island. She completed her residency in general surgery at UCSF and spent a year at the University of Minnesota to obtain specialized training in colon and rectal surgery. She returned to the faculty at UCSF in 2000, where she completed a fellowship in clinical outcomes research and epidemiology. Her research interests include the assessment of clinical outcomes and quality of life for patients with colorectal cancer, inflammatory bowel disease, and defecation disorders. Please give a warm welcome to Dr. Madhulika Varma.
Thank you. So, I was asked to talk about surgery for colorectal cancer and maybe some of the advances of treatment, and I just want to fully disclose that I have a lot of slides because there's really so much to say. There's so many different things to talk about, and I also speak very quickly. So if you feel that I'm going, it's too much, all the slides are in there and you can always peruse them at your leisure, but I'm going to kind of go a little bit quicker on some of the aspects and try to focus on some of the other more important things that I think might be of interest. And obviously I'm happy to answer questions in the panel. So anyway, what I decided to do is I split up the advances in treatment in 3 different sections. The first one is just actual surgical techniques. And as you heard, I take a special interest in doing minimally invasive techniques. And I'm going to talk a little bit about that as it pertains specifically to colorectal cancer. Then I'm going to talk also specifically about just advances in rectal cancer, because I think that's an area in which we've really made a lot of strides. And I want to share with you some of those issues. And then the last, very briefly, I'm going to talk about resection of metastases for stage 4 cancer. And as you all just heard, I'm a colorectal surgeon, so I'm the person that deals with the primary tumor. I work very closely with associates who deal with resection of lung and liver metastases. So I'm really just going to touch on that. But obviously, it's an important aspect of surgery for colorectal cancer. So the first step is, laparoscopic surgery has actually become extremely common. It's really done for just about every type of surgery. But, one of the key things, and I'm very proud of our particular society as colorectal surgeons, one of the first questions we asked when colorectal surgery was being done laparoscopically is, if we're going to do it for cancer, are we really going to achieve the same outcomes for cancer as we did with open surgery? And I would like to tell you that we're the only kind of area of cancer in which we have rigorously studied this in clinical trials. Laparoscopic surgery for pancreatic cancer, liver cancer, lung cancer never went through this kind of examination to make sure that this is true. And, the nice thing is this is just showing a slide of all the different trials that have been going on. The first one is an NIH North American trial in which they had 48 institutions participate in a randomized trial comparing open to laparoscopic surgery. And they've actually already reported the early follow-up and the 5-year follow-up. And now they're planning to, publish the 8-year follow-up, looking at the comparison of survival. And you can see there are 6 other trials that are ongoing that are, the rest of these are primarily in Europe. But they're all rigorously looking at this answer. And I'm happy to say that at least based on the early data, they really are the same. And that's the reason we do colorectal surgery laparoscopically for cancer. We had already been doing it for benign diseases. So you can see here the amount of bowel that can be removed, the margins that we obtain on cancer, which is an important thing, the number of lymph nodes. Many of you already kind of know that number of lymph nodes is an important aspect of colorectal cancer surgery. They're really the same. And this is from that NIH trial I showed you. The other trials really show the same thing, that they're finding that the recurrence rate, the survival rates, all are the same. So I would say laparoscopic surgery has really become the standard of care. And interestingly, I have found over the years of doing laparoscopic surgery that I even think I see things better. So this is just a picture. Is there a pointer here? This is just showing, this is a schematic. This is showing like the blood vessel, and you can see the little lymph nodes here. When I have my camera in, I can really see the origin of these vessels and really, in some ways, do a better anatomic resection because I can see it better. And you can see here, this is just a video picture of the same blood vessel, and I'm really getting in and getting down to the base of this. I'm also going to warn you, in honor of Halloween, I have some gory pictures, so just in case you want to avert your eyes. I'll try to warn you. I'm not sure if I can, but so anyway, another adjunct, and this has actually been an important aspect of certainly my practice and I think many other practices, is that we not only do we do the surgery laparoscopically, but we can do this what's called hand assist. And this is just showing, this is a little port here, and I can actually place my hand through here and use it like a laparoscopic instrument. So we use the camera and we use the different instruments, but this allows me also to have the additional tactile touch that I might need, for instance, to feel where the tumor is or feel where my margin is going to be. So that's also been a very nice adjunct and really eases the performance of laparoscopic surgery. The other thing is it allows for an easy extraction. One of the things about laparoscopic surgery for colon cancer is we still have to take out the colon, so we can't do it. People think like sometimes it's like a colonoscopy, like, oh, it's going to be an in and out surgery like a gallbladder. I'm like, oh no, you have to like take out the thing. So you still have to have an incision, and this is a nice adjunct. So what about robotic surgery? Maybe some of you have heard about this, and I appreciate this cartoon because actually my young 5-year-old daughter one time, she was yelling at me for coming home late from surgery, as I do many days. And she's like, Mom, why don't you just let the robot do the surgery for you? Because she's heard me talk about it. So this is not who does the surgery. It's actually still the surgeon. But why is that of any advantage? Well, one of the things is this robotic arm. What happens is you attach these arms, and then you sit at a console, and then you can direct the instruments to work. And the reason there is some advantages there is you can see better sometimes. The ergonomics of how you move the instruments can be easier. So this is more of just technical stuff for the surgeon, that might be of some advantage. And if you see here, this is the setup. looks very cool, NASA type, thing. There's a machine, and here's the robotic arms. And then, as you can see over here, the surgeon is actually sitting over here, and the assistant is the one by the table. So that's a little weird, it's like the person who's doing the operating is not actually next to the patient. But it does have some advantages. And, none of this has been proven yet. Robotic surgery has just kind of come on the horizon for colorectal surgery specifically. But, it's possible that maybe if you have this more precision or it's easier to use, maybe, there may be some improvement in the oncologic resection, as I showed you with the comparison of the open to laparoscopic. Maybe there might be some advantage there. Maybe we can pay more attention to the other structures that you don't want to injure, like the nerves, and maybe we can confer some advantage there. This is just actually a little bit of data from City of Hope Hospital down in Southern California that does do a lot of robotic surgery. And I just bring this up to say that when they looked at the predictors of how many patients had to be converted from a laparoscopic or robotic surgery to an open surgery because of, let's say, inability to look at the anatomy or worrying about injury or bleeding, they found that there was more conversions with laparoscopic than robotic. So that might indicate that there's some advantage there. But as I said, it's just not been done enough to really prove that there's any clear advantage, maybe equivalence. Challenges of robotic surgery, again, this is more of an issue just for the surgeon themselves, but just, whether or not it's worth taking more time or whether or not, if the instruments aren't as useful. You can only look in one particular place at a time robotically, whereas you can look in multiple quadrants laparoscopically. So maybe those things are not really going to confer an advantage to the surgeon. I would say as the patient, you wouldn't really know the difference. So the other thing that has come about, and this again has just really happened in the last year, is single port access. And you may have also heard about this for people who've had gallbladder surgeries done, that you only have one incision. So instead of having multiple little incisions used laparoscopically, everything is done through one incision. So you can see here, for instance, this is a smaller size port. These are essentially just different companies using different techniques, but that you would put all the instruments and all the cameras and everything through one port. I'm actually going to be doing one of these this coming week. The advantage there would be just less incisions. As a patient, I don't know that that's going to necessarily confer an advantage, aside from thinking it's maybe a bit cooler. We're going to see. But if in fact that there can be some improvement in patients' pain control or their recovery, certainly that would be an advantage in my mind. So we're going to see how that goes. So, I won't go over that. So then, as I already alluded to, we can't really remove incisions completely, right? Because we have to take the colon out. Here's just a picture of here's the piece of colon that's being removed, and then, we usually put it back together with staplers. Sometimes we use suture, and then we're dropping it back into the abdomen. So no matter what, we have to make some kind of incision. So we can't eliminate that completely. But one thing that we can do is decide, where we're going to take out this specimen. I often make a C-section type incision for my surgeries because I think people recover from that much better. Cosmetically, it's nicer for patients. But now there's more and more experimentation being done with retrieval of the specimens through other orifices so that you could eliminate that incision. So for instance, it's called NOTE surgery, natural orifice, I don't know what the TE is for, but anyway, natural orifice extraction. So for instance, taking out, the colon through the vagina, if you're a woman, of course. Can't do that if you're a man. Or through the anus, So some of these things are just starting to come about, and we're trying to see if we can further improve. Really, that's not an issue of cancer recovery, but that's an issue of just personal recovery for the patient. So we're constantly working on those kind of things. Okay, so that's kind of what's new on the surgical horizon. Now I'm going to talk specifically about rectal cancer, and what are we focusing on in rectal cancer really in this decade or in this century? We've already come a long way from the initial treatments of surgical cancer from the early 1900s. It used to be the vast majority of people who had a cancer in the rectum had to automatically have a colostomy, for instance. Really, the focus was on just doing the surgery. We had no other way to manage recurrence, meaning the cancer coming back. So already now the standard has become, we use chemotherapy and we use radiation therapy to help with that. We are able to really push the barriers in terms of sphincter sparing operations where we can put the patient back together and not have them have a permanent stoma. And so I'm just, going to talk a little bit about how we've been able to achieve some of those goals and what are we doing next. So the very first step is,
let me just go back, is how do we improve the local control, meaning, you know, we're going to do the surgery and take out the rectal cancer, but how do we keep it from coming back? Because that's obviously extremely important. And one of the things that's really helped is our improved imaging. We use a combination of CAT scans. This is an MRI. This is an ultrasound. I think Dr. Vinook mentioned I do a lot of ultrasounds for rectal cancer in my office because it shows me, here's, you can see it looks like a snowstorm with a circle in the middle, but this is kind of the way the walls of the rectum are supposed to look. There's like 3 layers, and here you can see this black thing sticking out. So it shows me how far the tumor is extending through the bowel wall, and then it also lets me look for lymph nodes so that I can see whether or not a patient is a candidate for radiation therapy to help treat the tumor before surgery or not. And then this is a picture of a PET scan that also can show us if the tumor's lighting up. So that's really helped us a lot in terms of planning our treatments for rectal cancer and what we can do or not do. Again, Halloween pictures here. This is just showing, you know, this has been a huge revolution in the surgical world for reducing the recurrence rates of rectal cancer specifically. In the past, the recurrence rates used to be on the order of like 30% or so. And then with the advent of radiation, we were able to reduce that recurrence rate to around 6%. But an interesting thing, there was a surgeon in the UK named Bill Heald who began advocating this total mesorectal excision. And if you research rectal cancer, you'll see that word come out, or this phrase come up over and over again. What that means is, you see this like glistening surface here, is that when you take out the rectum, you take out all the associated fatty tissue that contains all the lymph nodes, and you take it out intact. And that actually is as important in treating patients and preventing recurrence as the radiation. Okay, so the radiation used to kind of make up for that a little bit, and now we found that the surgery is just as important. So you want to make sure, you know, when I take out, we always joke that these pictures, you know, we glisten some olive oil on here and make it look really nice. But, you know, you want to see this glistening, intact capsular surface. That's what we aim for, and when I do surgery, I'm looking to make sure this is what it looks like. So this is just a cartoon kind of showing graphically what I'm talking about. So you see here's the rectum, and there's the inside of the rectum, and here's this tumor. So what I'm aiming for is to excise the fascia propria of the rectum, which is that glistening surface I showed you, so that in the entire mesentery is removed that contains all the lymphatic tissue and all the lymph nodes. And I have to achieve this when I'm doing this type of surgery, or I have not done the patient any favors. This is just a picture showing some pathology studies that actually, you know, then sliced up, you know, these specimens, and you can see here's the glistening surface, as I showed you, here's a broken up surface. And so then when they did cross section, see how these are nice and round, which is what you want to see, and these are not. So you have risk of having recurrence, that tumor cells are left in place or lymphatic glands are left in place. So you want to, and this is also alluding to the whole issue of general surgery versus colorectal surgery. Colorectal surgeons do this always no matter what, not because they heard that TME is an important thing to do. This is how they always remove a rectum, and this is the difference in recurrence rates. So here's just a picture showing for those patients who have tumors that are really on the sphincter muscle, and you know, as I said, you know, it's like limbo. How low can you go? We go as low as possible, but sometimes if the tumor is really within the anal canal, onto the anal skin, or in that sphincter muscle, we have to do what's called an abdominal perineal resection with a permanent colostomy. And this is just a picture showing that even when we do that, there is a technique to it that's important. It's not just about removing the anus, but making sure that you removed all the muscle in like a cylindrical fashion and not coning it in. And that's something, again, if you look at this cartoon here, many people when they're removing the rectum, this is the upper rectum here, they kind of cone in and they move into this area because it's surgically kind of easier to remove. You want to avoid that and make sure that you're taking it out straight so that you get this nice surrounding fatty tissue around the whole specimen. Again, another thing that reduces the rate of recurrence. So these are important surgical issues for rectal cancer. And this is just showing a couple of studies that have shown that when there's variation in those techniques, there's variation in recurrence rates. So we want to be sure that we're paying attention to that. This is just also showing the sphincter saving procedure. So for those people who have the tumor is low, but not so low that they cannot be put back together. And this is just showing different aspects. This is a tumor more of the sigmoid colon, so this lower part of the bowel is removed, and then this part of the colon is taken down. The attachments are taken down, so it'll reach down to the rectum and put together. Here's an example of where the tumor is lower down in the rectum, but not so low that it's on the sphincter here. So this part of the rectum and the sigmoid colon is generally removed. Again, you have to take down the attachments of the colon here, and then you get the colon to reach down to the anus. And this is where laparoscopic surgery really helps us, because in the old days, to get down all the attachments of this colon up here, that's up here and under your chest up here. We used to have to make an incision that went, stem to sternum kind of thing. And now we can do all of that using that smaller, lower incision and use the laparoscopic instruments. So that's been really a big improvement for the patient's recovery. This is showing a laparoscopic picture of putting the bowel together. For this type of surgery, we often use staplers to put the colon together with the rectum. If the tumor is really like low, like as low as we would normally go, then we often have to suture it by hand, and we use stitches to do that. And this is just showing a picture of, how low can we go. We can really take it down almost, as low down into the anal canal. The key here, though, is that this tumor cannot be extending into the sphincter muscle. And that's what I check on the ultrasound and what I check on the exam. And sometimes I'm even checking it in the operating room. And it cannot be going into the anal skin here. So we can take it down as far, pretty far, farther than you'd imagine. But there's only a limit to that. The second thing, and this is just another gory picture here, this is just showing how the specimen's being removed through the anus. And so this is another example of mobilizing the whole colon and rectum, removing it through the anus, and then hand suturing it back together. And this is just the suturing. I'll skip over that. What I wanted to focus on, I know a lot of people are not going to want to see that. What I want to focus on, though, is, sometimes technically, I can take this and prevent a colostomy, but sometimes I'm not doing the patients any favors. And I bring this up all the time in the office when I'm speaking to patients about this. I can bring the colon down and bring it right down to the anus, as far down as possible, but there's a huge price to pay in terms of bowel function. And people have to put up with that, and they have to figure out their diet, they have to figure out their bowel habits, kind of even their daily regimes. It can have significant impact. And sometimes, depending on your age and depending on other factors, they may have changed the strength of your pelvic floor muscles. You can have big issues with either control, with urgency, clustering of bowel movements, severe dietary restrictions because, whenever you eat spaghetti, everything pours out. So there's a lot of issues that can occur with that. And one of the things that people have tried to figure out different ways to connect the bowel to try to make it easier to achieve that function. And so sometimes people have created these pouches or mini pouches, and some of that helps a little bit initially, but the truth is all these things kind of have the same level of bowel dysfunction, 1 year out. So people are going to kind of continue to improve for 1 to 2 years, and then they're stuck with where they're at. So I will often sometimes tell people that technically, I can do this surgery for you, but maybe you're going to be better off, maybe an older person, let's say, or someone who's already had injury to their anal area, something that's going to affect their control. I'll say, I don't know that this is really the best thing for you. It's like, I can do it, but I would suggest you have the colostomy. And unfortunately, I don't have enough time to really just speak about colostomies, and I know that's one of the topics that was of interest to this group, but people live wonderfully complete lives with great relationships and do every activity possible, including surfing and heli-skiing and all kinds of stuff. And, I think I only wish I could educate people more about how that is a totally achievable thing, because people are always just so scared of that. So, but I'll leave it at that. Here's just a little bit of data on, 40% of people are having defecation problems with that low anastomosis. So it's a huge group of the people. And actually a fair amount of people are also having issues with urinary symptoms. That and sexual function has to do with those nerves that we talked about, trying to spare. They sit behind the rectum. When I do these kind of surgeries, I'm always looking for those nerves, but especially in the setting of having had radiation, there's kind of additive injury that occurs. And so you can see about a third to 40% of people are having issues with just pelvic function, bowel, urinary, sexual. And that's a big issue. So what can we do better about this? Am I doing okay on time? Okay. So what can we do better about this? I've just explained to you, we're attacking patients with the radiation and the surgery, and your bowels are messed up, and it sounds terrible, right? Well, one of the things that we are focused on in terms of the treatment of rectal cancer is if you have an early tumor, maybe we can spare the radical operation. Maybe we can do a local, more focused excision. And this kind of speaks to kind of what's happened in breast cancer, for instance, where it used to be large excisions and now people are getting more focused excisions. So can we do that? And then, as we talked about, Dr. Vinook mentioned how our chemotherapies are getting better and better, and we're starting to talk about cures. Well, if we use these better chemotherapies and the radiation, can we reduce the scope of therapy? Or the latest question is, can we avoid it altogether? Which is, would be amazing. It's put me out of business, but it would be a great thing to do. So first thing I talked about, early cancers. Well, the key is, how do you detect an early cancer? How can you be sure it is an early cancer so that if you do less surgery, you're still going to achieve a cure? Because that's the most important thing that we're trying to achieve here, right? Well, ultrasound is a very important way because we get a very good view of the tumor in the bowel wall. You can see, compared to that other ultrasound I showed you, which was like sticking out to here into the fat, this one is contained within the bowel wall. You also, we can scan the lymph nodes, and so we can see that there's no lymph nodes involved and that those don't need to be removed with surgery. So maybe this is a person who could get a local excision of the tumor. Here's just a operative photograph showing here's the tumor here in the rectum, and so we're trying to take a good margin all the way around the tumor itself, and we remove it and then we stitch it closed. We often can do this through the anus if the tumor is low enough, and there's also a new technique called transanal. It's not that new actually, but new to UCSF. Transanal endoscopic microsurgery, where we actually can use like a limited scope. It's almost like a little laparoscopic procedure through the anus, and we can use a camera and instruments and actually do lesion excisions more proximally. And actually I have a new partner who did some additional training at Sloan Kettering who is hopefully going to get this going at our institution. Here's just showing the picture. The key here is, even if you're going to do this local limited procedure, you better make sure you have a good margin and that you've taken out the entire wall of the tumor, because otherwise if you have a positive margin, then again, we haven't helped you. The advantages, obviously, is that you're doing this limited procedure through the anus, none of those sexual, urinary dysfunction, all the stuff I talked about. So that's really great. But the downside is, if you do that, you're not removing the lymph nodes, and even if we ultrasound and we do a CT scan, it's still not telling us if there's a cancer cell in there. We don't have any perfect way to figure that out. And you'll have poor results and high recurrences if these patients aren't carefully selected. So it's not something to be taken lightly. We really try to be absolutely sure that we think this is going to be the right thing to do. And I sometimes will even tell people, I'm going to treat this local excision like a biopsy. So if I remove this and there's any factor, when I get the pathology back, anything looks concerning, you're getting a radical resection. So, I don't want to sound like, oh yeah, we can just kind of shave this off and it's going to be good. If it's not treating the cancer, it's not good enough. So what about the tumors that aren't very early? One of the studies that we're involved with is actually trying to give chemoradiation before surgery to see if we can downsize that tumor and make it easier to resect. We only still want to do this though on tumors that don't have nodes, because we just talked about, even if you give the radiation and treat the nodes, if you leave them in there, they still can grow back, right? So this has to be in tumors that are confined to the bowel wall where you treat it and then you're going to remove it, but not in those that have lymph nodes positive. So, the advantage is just so you're going to reduce the tumor size, and then the downsides are that, after you give the radiation and you cut it out and suture it together, you may have some difficulty with wound healing. But this is just actually the American College Oncology Group. This is a trial that we're a part of, where if patients have a tumor that's contained within the bowel wall and no lymph nodes, then we'll give them chemoradiation therapy. And then we do an excision, and if the tumor has negative margins and it was still just contained within the bowel wall, we'll observe them. But if the tumor extended through the bowel wall on that excision, or there was some other worrisome pathologic finding, or the margin was positive, then they have to undergo radical resection, which is kind of what I was talking about here. So that trial is kind of ongoing and is just about to finish accruing patients, I think, probably by this coming spring. The next thing I want to talk about, so for tumors, for all rectal tumors, we know that all of them are kind of responding to some degree to the chemoradiation therapy that we now kind of by standard give before the operation. And kind of in the past, about 20% of patients, when we take out the cancers, have no cancer in them, take out the tumors, or the rectums, I should say, have no cancer in them whatsoever. So that's kind of very compelling. It's like, who are those people who are having such good responses to the radiation that there's no tumor left? The problem is we don't really know who that is now, so we have to still do the standard of care, which is to take out the rectum and do the surgery. But when we find this, we think, okay, well, what else can we figure out about the patient or the biology of their tumor that might tell us who has that complete response? So we are now, this is just a picture showing It's a little hard to see, but this is the rectal cancer before the radiation, and then this is the surgical specimen where it's been removed, and all that's left here is a scar. So you can see a response here. The problem is that different people, as I said, have different responses to the radiation. So some people have a little dot left, when you remove it. Some people just have scar tissue, and then some people just have a full-on tumor. They just don't have the same level of response. And at this point, we don't really have a good way of figuring out who those people are. So one of the things that people have tried to figure out is, can we do some kind of imaging study to figure out who's had responded and who hasn't? Now, we know that imaging is not going to show you a residual cancer cell, right? So it's not perfect. But, is that possible? Well, this is an ultrasound showing the tumor before radiation, and then you can see the afterwards. And it looks like there's something there, but the problem with ultrasound is, what's scar tissue, what's tumor, we can't really figure that out. So it may give us a sense of response, but it's not showing us who's completely resolved. Here's PET scan, which also seems maybe more compelling because you see actually something light up when there's cancer cells, and it goes away when you saw Dr. Wang showed a PET scan of before and after treatment. So, that might be a compelling factor, but, it's hard to really see things that are less than a centimeter on a PET scan. So if you have cancer cells, but it's too small to detect, this may be a false sense of security. So it's not ready for prime time yet in terms of figuring out imaging studies that are going to help us know what to do. So once again, we're part of an NIH trial that was actually originally based at UCSF, but now we're one of the sites where we're looking at the role of chemoradiation prior to surgery, and then looking at the interval of time between the radiation and the surgery itself to see, are more and more people getting a complete response if we wait long enough after the surgery is done. Because we do know for a fact that the radiation keeps working after the treatments have completed. So now we're thinking, well, maybe if we waited longer, we can figure out, will more people respond? And on top of that, we're now looking at those specimens and looking at molecular markers to see, who are those people. So this is just the protocol showing that, this is the standard, which is people get chemoradiation therapy for 5 weeks, and then they were getting surgery at 12 weeks. And now what we're doing is we're extending the interval. You see 16 weeks, 20 weeks, 24 weeks, and people are getting chemotherapy in the middle just so, some treatment is going on, and then we're looking at those specimens. And the early data does seem to show that the complete response is increasing as we extend the interval. So I'm just looks like I'm running out of time, so I'm not going to talk about the metastases, but they're in your slides. But just, in summary about the rectal cancer, staging before treatment is extremely important, particularly in rectal cancer, but obviously true of colon cancer too. You want to make sure that there's no sign of metastases, that that you should actually be seeing Dr. Vanook first, for instance, to getting chemotherapy before surgery. The total mesorectal excision, as I told you, is one of the important surgical tenets that has to be done when you're treating a rectal cancer. And then most patients who are having advanced rectal cancer really should receive the chemoradiation therapy beforehand, and that's why the preoperative staging is so important. Any deviations like watchful waiting, after chemoradiation should really only be done under the setting of trials, so we're not advocating that. The standard of care for rectal cancer that's advanced is still to get chemoradiation and get surgery, in spite of some of these promising characteristics here. And, uncertainties about our tumor response to chemoradiation therapy is really an opportunity to investigate how we can further help that group of patients. So I'll stop there.
Well, I'm very honored to introduce our final presenter for this morning's session. Dr. Robert Curlin is Chief of Interventional Radiology at UCSF. Dr. Curlin received his medical degree from the University of Southern California in 1977, completed an internship in internal medicine at UCLA in 1978, and was trained in radiology at UCSF, where he became chief resident in 1981. He was elected to Alpha Omega Alpha and was recipient of the Clarence Heller Fellowship in 1978 and the UCSF Exceptional Physician Award in 2004. His principal research interest is the management of malignant hepatic tumors. Please help me in welcoming Dr. Robert Curlin.
Thank you. We've heard a lot of interesting presentations this morning, and I want to emphasize that one of the advantages of coming, and this isn't, it's not a shill, because you can get this in other centers other than the UC system. But I would encourage you, if you have or a loved one has a colorectal tumor, to go to a center that routinely has a tumor board where representatives of different specialties, such as Dr. Vanook, who specializes in colon cancer, or Kim, who specializes in the treatment of metastases from colon cancer, as well as in aiding the treatment of the primary disease, or Mika, where they have specific surgical expertise, or us in interventional radiology, can sit and talk specifically in depth about the results that they are getting. And that way, I think you benefit from the opinions of lots of different people. And I think the cooperative aspect of working in a large medical center is really to the benefit of the patient. Now, what I'm going to talk to you about is interventional radiology, which, you know, when I'm on an airplane and somebody's chatting next to you, and you guys all know if somebody sits down, they want to talk, and you think, oh, God, I want to talk, I want to talk. And they ask me what I do. You know, I usually say plumber. Because, you know, most of the time, people don't know what an interventional radiologist is. An interventional radiologist is someone who does many procedures under imaging guidance. I read very few x-rays, despite the fact that I'm a radiologist. What I do all day is I put catheters and tubes and needles into people, either under fluoroscopic, ultrasonographic, or computed tomographic guidance. That's what I do, but most people don't even know that I exist, so I'd rather not get into it, and I just say, I'm a plumber, that's what I do. But we do lots of things with cancer. I would say that about 60 to 70% of patients that I see during the course of the day have some form of cancer. And that occupies really the principal part of my practice. And we're really involved in two aspects of it. And the first is diagnosis. Now, we do very little with diagnosing primary tumors of the colon and the rectum. That's usually done by the gastroenterologist, proctologist, people who are examining the patient, feeling a lump, somebody presents with bleeding, and they look and they can see it. And the standard treatment for that, as Mika has said, is pretty established. People can figure out what the extent of the tumor is, and they can recommend on the basis of what the primary tumor is, what should be done. And we don't really get that involved in that level. It's not until somebody shows up later with a spot. And that's where we come into play. Now, as far as diagnosis is concerned, most of the time what we're doing is we're trying to establish the fact that somebody has either nothing, which is what everybody wants you to have, or metastatic disease. And the way we do it is that, as people know who've had cancer, you undergo a series of scans. It might be a PET scan, maybe a CT, it may be a CT PET scan. But sometimes you'll show up with the thing here, a little spot. And heck, you know, what is that spot? And they, God, you've had cancer, and as we know, all of the blood flow that goes to the bowel drains through the liver. So it's not unusual for people to show up with spots in their liver. And the question then becomes, because, you know, not everybody out there just goes in and gets routine CT scans. Was that spot there before, or maybe you had a scan before and the spots appeared? What is that spot? It becomes very important if that spot can be established as a spread of your tumor. How are you going to figure that out? Well, in the old days, back when I was growing up in LA, you guys remember a long time ago, they used to do things like exploratory laparotomies. They'd actually cut you open and fool around in there and try to cut a piece out to see what it was. You don't have to do that these days. What we do, and we do this every day, are what's called image-guided biopsies. If you see a spot on the CT scan, we can take a little tiny needle and in the CT scanner itself, put the needle into that spot. And all we need is just the tiniest bit of tissue. And these needles are designed just to take out just a little tiny, and sometimes they're no bigger than, you know, a big grain of sand. And when they look at that under the microscope, they can tell if that's tumor or not. And that's a big advantage to the patient. We can do this as an outpatient. It's not a nothing. And I'm one who is very sensitive to having needles poked into me. You know, a lot of us are like that. I hate needles, and I hate pain. That doesn't separate me from anybody. I've been practicing medicine for 30 years, for somebody to come in and go, oh, I like shots. Nobody likes shots. But it's not excruciating agony. And we do have, the ability to give sedative medicines, which kind of puts you in a state where you think, oh yeah, it's all right. But it's like a trip to the dentist's office. The dentist is going to give you a shot, and it hurts for a little bit, and it makes it numb, and we put that in. And it's a very low-risk procedure. Nothing's zero risk. When you get on the Southwest Airlines and they say, in the unlikely event of a water landing, you're thinking to yourself, in the unlikely event of a water landing, what you're about to say is completely moot because we're going to be swimming. But it is a very, very safe and it's a highly accurate procedure, and it's one of the major contributions that we make. Now, we're going to move away from the diagnosis, and that was just saying how we establish the diagnosis, into the area of treatment. And the interventional radiologist can treat lots of people with metastatic disease. But I want to emphasize that all of these things that we offer are in addition to the conventional and standard accepted ways to treat metastatic disease, which is usually a combination of systemic chemotherapy and radiation therapy. The reason, as Mika said in her showing of the ultrasounds, was, it's not really what you see that gets you. It's what you don't see. If you see it, sure, you can take care of it, but you can't tell the difference between a scar. And little tiny cancer cells can exist that we don't see. Therefore, it's very important to undergo the standard systemic treatments for these diseases in order to prevent something from becoming apparent. Do you ever notice it's not the highway patrolman that you see in your rearview mirror that gets you? It's the one where you're driving down the road, and I don't know where they come from. All of a sudden, they just appear. They're right behind you. And if you're like me, when you see those guys behind you, no matter if you haven't done anything at all, your heart starts beating fast. And then those lights come on, and you have to talk to them. It's pretty icky. We do quite a few things, and they're divided into two groups. One are the arterial therapies, and we'll talk a little bit about chemoembolization and radioembolization, which are certainly topical issues for those of you who have done any research into the management of colorectal metastases, as well as percutaneous ablation, which is the other large thing that we do in our practice of interventional radiology. Go forward. Now, with regard to the arterial therapies, this is a beautiful thing. The liver is uniquely set up for being treated with an arterial therapy. Why? Because all of your bowel drains through the liver into a large vein called the portal vein. And the portal vein actually supplies 3/4 of the nutrients to your liver. The artery, everything's got to have an artery in the body, and there is an artery that goes to the liver. Now, it turns out, and this is one of those things you got to accept like geometry, the axioms, you just got to believe this, and I don't know why it occurred, but it turns out that primary and metastatic tumors of the liver derive usually more than 90% and sometimes 100% of their blood supply from the hepatic artery. Well, what's that mean? We can do a trick. We can do a trick by putting a little catheter into the artery, going to the liver, and injecting some toxic substance. And it will kill the tumor, which is getting most of its nutrients and blood supply from the artery. But the liver, which is getting 3/4 of its flow by the portal vein, is fine. So we can selectively kill tumor in the liver. It's a great trick. And I think I have a couple of diagrams to show you in just a little bit. And then what we do is we get into that artery that's supplying the tumor, and we can put, chemotherapy in it with also an embolic agent. An embolic agent is just something that blocks up the blood vessels. So if you're sitting there and you're the tumor, you're getting all your blood supply coming from this artery, and then somebody puts some poison in there and then puts a plug behind it so that poison just sits there in the tumor. If you're the tumor, you're going, oh man, this is bad. And what happens is you get a very high concentration of the chemotherapeutic agent in the tumor itself, and also you're choking off its blood supply. When you put those two things in combination, you get a high incidence of death in that tumor, which is being supplied by the artery. Also, an advantage of using this form of therapy is you're not giving a lot of toxic substance into the vein. What's that mean is you don't have a lot of systemic side effects. I'm not saying this is any walk in the park, and cancer treatment isn't something that you should expect to be just, like a nothing. People don't feel good. Don't feel good for 3, 4, 5 days, but it's generally just an overnight hospitalization, or we can send you home the same day as an outpatient. And particularly if we cause a lot of death of tumor, you don't feel very good, kind of, malaise. Sometimes you get a little low-grade temperature, but it really doesn't last very long. But you don't get the same side effects. You don't get a loss of hair, itching, the neurologic side effects that Alan was talking about. And for that, it's pretty good. And this is just a diagram of how the liver gets most of its blood from this big vein, which comes up from the gut. But the arteries supply the tumor. And as you can see, if we can wiggle a catheter out there, and you can say, well, how do you do that? Well, it's like anything else. This is what I've been trained to do over time. And, I've spent years of figuring out how to wiggle these catheters into the fine spot. And even though I'm talking to the guy on the airplane, I don't want to tell him, how I figured out how to do that. So I've done this every day for a long time, and I can figure it out. So we can get the catheters actually very close to the tumor. And when we do that, we go ahead and inject a combination of the chemotherapeutic agent and the embolic agent, and then it sits there in the tumor, and the tumor dies and shrinks. And that's exactly what's done. And this is just a picture of somebody with a fairly large tumor occupying the posterior aspect of the liver. This puppy here is the liver. This dark spot is the tumor. And you can see the white stuff is something that we can put in to see the area that we're treating on a CAT scan as this tumor treats. But the whole thing is filled with this toxic agent. In the future, there may be some very specifically directed chemotherapies. People are experimenting now with these irinotecan beads, which is a type of chemotherapy which is used in selected patients who may be resistant to the other forms of chemotherapy. They're having fairly good luck with this in Europe. It's just in trials now in the United States, but certainly in the future, this may become a very important part of management of patients who have colorectal tumors which have metastasized to the liver. And we can get some pretty dramatic results. Here's someone, and I'm not going to show you this. This actually is somebody with a primary liver cancer, but we've had other patients with metastatic disease who have the same type of response. We go ahead and inject the tumor with these little tiny catheters. And, this is a film from 2 months later, and they actually went in to resect this area, which had shrunk from 7 centimeters down to 3 centimeters. And did you know in the resected specimen, there wasn't any live tumor at all? They looked at it, and the whole thing was dead. Radioembolization is another form of therapy which also takes the same advantage of a chemoembolization by utilizing the arteries as the highway to the tumors. And what's done in this circumstance is rather than putting in poison, you put in little droplets which emit electrons. Now, why don't people who have liver tumors just get big external radiation to the entire liver? Well, the reason is that the normal liver cells are also sensitive to radiation, and if you gave enough to kill all the tumor, you'd also kill all the liver, which is a bad thing, because there's not like liver machines out there that can take care of you. But if you use these, and this is for people looking on the web, the SIR spheres, the Therasphere thing that comes on, these emit electrons. And electrons are also known as beta particles. They don't go very far. They just go maybe 5 millimeters inside tissue. They don't even make it outside the body as a primary form of radiation. And what happens is, since they're big, they run into a cancer cell if you put them into the artery, and it kills that cancer cell locally. And because, as I told you before, the tumors derive the vast majority of their blood supply from the arteries, you don't kill the normal liver cells. All of that arterial radiation preferentially goes to areas of tumor, emits the radiation, And that's where they're starting to get really pretty good results in doing this. And this is just a diagrammatic example of sticking these little tiny catheters in and injecting the radiation. Much higher concentration in tumors than the normal liver. Preferential flow to tumors because they're hypervascular, at least to a certain degree. And they get trapped there and they sit there and they emit radiation. And we're getting some fairly dramatic results. Here's someone who we tried chemoembolization. That's that little dot of white stuff, but it didn't spread all the way throughout the tumor because you can see that there's a lot of activity, and that's that white spot in the PET scan. After doing the SIR-spheres, you can see that the area now is all dark and necrotic, and now there's no activity in that same region on the PET scan. So we can assume that that tumor is controlled. And this is just another example of a patient who had metastatic disease to the liver, treated with the SIR-spheres, and you can see just at 1 month that tumor shrinks down. Let's now change gears and go into the area of percutaneous ablation. Now that's different than the arterial therapies I've talked to you about. What's this deal with? Well, it deals with usually sticking something into the liver to kill a region of tumor. And there's lots of different ways that it's done. I'll go through this. All these techniques share things in common. One, they can be done in the CT scanner percutaneously. They can be done by MICA, laparoscopically. You can do it during the course of an open surgery. The mechanism is a little bit different, but most of the time what you're talking about is applying heat. And, you know, I won't mince words here. You can say, well, we're giving heat. You're actually just cooking a little area. I mean, you're just cooking it. And when you get tissue above 60 degrees centigrade, it dies. It doesn't work anymore. That's why people burn to death. I mean, you know, you just can't burn and live because it kills all your cells. And there's a lot of different endpoints these different machines have, and I'll just show you a few of the devices, but all of them have some adverse effects. I mean, yeah, you can get some pain. Anybody who's had surgery knows that 100% of the time you have surgery, you do have pain. Cuts hurt, okay? The pain's usually easily controllable by oral medication, lasts for 24 hours, not a huge deal. You can get bleeding. There's blood vessels in there. If you happen to hit one of those blood vessels, you can bleed. You can hurt things if you're not really careful to avoid applying this energy to areas where it shouldn't. You don't want to hurt the bile duct. There's places where you can hurt the diaphragm. But all in all, when you're doing this under imaging guidance, you can see these structures and you can avoid damage to them. And this is not a real dangerous thing. The incidence of significant side effects using this form of therapy is usually somewhere between 1% and 3%, and even those can usually be handled without difficulty. The other good thing about ablative therapy, in comparison to something like chemotherapy, which sort of depends on the chemosensitivity of the tumor to the specific type of agent, is that all tissue responds to heat. If you get any tissue hotter than 60 degrees centigrade, it dies. So there's no resistance. But the downside of it is it's only appropriate for selected patients who have a limited tumor burden. You know, it would be great to think that you could take these devices and kill 120 spots in your liver. The problem is if you have 120 spots that we see in your liver, there's going to be more spots that you don't see, and it's really not worth going through it. So basically where this has gone is patients treated with these percutaneous ablative therapy are limited to having 5 or less lesions, and none of the lesions exceed 5 centimeters in size. I will go even farther. I will say where this works best are people who have tumors that are less than 3 centimeters in size, because it turns out in those circumstances we can kill an area around the tumor, get the whole edge, and the incidence of having complete necrosis in those patients is much higher than in comparison to patients who have larger tumor burdens. I'll just go through a couple of different types of things. What is radio frequency ablation? Now that's a fancy term for making heat. Why do they call it radio frequency ablation? Why don't they just call it killing through a heat probe? Which would be just as good of a name, I can guarantee you that. The radio frequency aspect of it is it's alternating current. And so when you go, the current goes one way then the current goes the other. And what happens is all the ions in there start to get confused, and they're going back, they go forth, go back and forth, and they start to rub against each other, and that creates the heat. And they apply the name radio frequency ablation for it. The reason that we can get large areas of kill is that they have specialized needle designs, and you have these needles that go in, and they have little tiny radio frequency prongs that extend out away from it. Therefore, you can get an area of kill surrounding this entire umbrella, or if you're working with another company without the tines, they can circulate water through the probe itself, which creates a much slower burn. Or this is called a starburst pattern. I thought starburst was something that you bought down at the candy store, but they adopted that, and they say that that's the starburst probe. But really, it's all the same. It's all the same. And you'll hear things on the radio about, specific things that people have. It's all the same stuff. It's just a way to give heat to an area of tumor and kill it. And this is, we do this in the CT scanner, so we can see that we're right at the right spot. And this is just one of those probes, and you can see it kills all the tissue around the probe. And because these lesions are detected on the basis of the CT scan, we can be pretty sure that we got most, if not all, of the tumor. Here's another patient where you can see there's a white spot representing a tumor. Put the radio frequency probe in, and we kill a larger area than the tumor itself because we want to be sure we get the entire edge. Just like Mika was saying, you got to get what you don't see. So we try to take a margin around the tumor itself to ensure, at least in that lesion, most of the lesion's been killed. We can combine these techniques. Here's a patient who had a chemoembolization but had some holes in it. We weren't really sure that we killed it all with the chemoembolization. So you can go back, and then you can stick a probe in several areas in this tumor and cook it too. It doesn't bubble or do anything. And this is a year and a half later. This patient was totally stable. This lesion never came back, and we considered it cured. Microwave. Yeah, you can go to places where they say, well, we don't use radio frequency ablation. We use microwave ablation. Same thing, just makes heat. That's all it does. And everybody's cooked things in the microwave. It's one of the greatest things that ever happened. When I was, I think, in the 7th grade, my buddy had one of the first microwave ovens. You could take one of those frozen burritos, throw that puppy in there, and 3 minutes later, you could eat the burrito. It was a great thing. Same thing is happening in the body. You can put a little antenna, it's a microwave antenna, right into the tumor, apply microwave therapy. Is it different than radio frequency? Yeah, it's got a different name, but it's the same thing. You're applying heat to raise the tissue temperature above 60 degrees and killing it. And this is just an example of what a microwave ablation device looks like. Again, it's a little probe. We can do this either under conscious sedation, which means we don't have to put you totally asleep, or to make it more comfortable. Some people aren't even interested in playing. I want to be asleep. That's fine. I'm going to put you to sleep and just stick this needle into the liver and cook the lesion. How about laser? Everybody loves lasers. Lasers, when we were growing up, always were something that representing high tech. Okay, great. You have a laser. I think that most of this was stimulated by James Bond, Sean Connery, who's the real James Bond, as we all know, lying on the table, with Goldfinger getting ready to cut him in half with a laser. And laser, I'm going to do that. But, a laser is just another way to apply heat energy. Mm-hmm. So in some centers, they're using what they call laser interstitial thermal ablation. Doesn't matter. It's just another way of applying heat and killing tissue. And whatever devices that who's ever treating you or your loved one is comfortable with, that's what they should use. That's what they know. Cryo. We've all seen, how many of you guys read that book about the Everest thing? They were climbing up Everest, the guys up there, and they get real cold and their fingers would fall off. I think that Beck Withers guy, that pathologist guy's nose fell off because he's got frostbite. Therefore, if you get something cold enough, it will die and fall off. And the same thing can be used to treat tumors of the liver. We can use a probe. I mean, I've read a lot of books. I still don't understand how you make things cold. It has something to do with gas expansion and PV equals nRT and something that I learned. But trust me, if you put a cold gas and let it expand, you can make something really cold. And what happens, you can see these probes, and if you do it in water, they actually develop an ice ball around the tip. Well, you're just giving a little local frostbite to the tumor in the liver, and you make it real cold, and you let it thaw, and you make it really cold again. And as you know, frostbite causes things to fall off, so you can use this to kill tumors. And this is an example of a laparoscopic cryoablation. You can see that ice ball forming right on the surface of the liver. And it just is just a big old ice ball. And if you freeze something a couple of times, it kills it and it doesn't come back. There's a new thing on the horizon, and this isn't anything that we're doing now with any regularity, but it's just another way to kill tumors. It's called electroporation. Again, a big fancy term that not too many people get, and I think that's part of what the medical industry does. It's sort of disguise what they're doing by making terms that are a little bit difficult to understand. This is just the application of current through tissue, and the current in itself alters the cellular membrane and can cause cell death. It does it without heat. It doesn't make any difference. What if you use heat versus not using heat? It's just another way to put a needle in and kill things in the body. And the beauty of it is you can do it very accurately under imaging guidance. And this is what I do for my living. And you can see what you're killing, and that way you can spare yourself from destroying normal structures which might lead to complications. In conclusion, I'd like to say that what we really need to do with all these emerging technologies is study them closely. And it's frustrating. It's a frustrating time for everyone because the technology is outpacing our ability to understand where they can be appropriately applied. You shouldn't have some high-tech treatment just because it's a high-tech treatment. Treatments that people receive should be grounded in scientific study where people actually can know by comparison of two groups of patients with different types of treatment actually who lives longer without disease. And the trouble with all of these things is we're just in that stage where these studies are going on, and we don't know the answer. We don't know whether it should be an arterial therapy combined with chemotherapy, but that's the importance of supporting scientific research. And actually, if someone offers you at some time to be involved in a trial, that's the importance, so that we can figure it out, that we know what is best to do for an individual patient. And yeah, we've got some great toys, and I think that will be important for very selected patients who have things in their body, metastasis to the liver, metastases to the lung, and we will be able to do this. But, you know, it's just not totally worked out yet, whereas if, you know, you filled in a paper and says, this is what I have, is this best for me? We just don't quite know yet. But there's a big future in this because it's a treatment that can be combined with other types of treatment. It can be done repeated. It can be done almost as an outpatient in most individuals. Thank you very much for your attention. I really appreciate it.
Okay, we're going to get started now, and what we've got is I've given all the doctors your questions on the cards, and they're going to try to go through as many of them as possible in the time that we have allotted. And if there is any extra time, we'll see if we can take some questions from the audience, but I'm just not sure if we will be able to have that time, because as you can see, we have quite a few questions up here. And I'm sure that there's probably some questions that more than one person asked, so they will try to put those together and answer one question if 2 or 3 people ask the same question. And again, as Naomi mentioned earlier, if you did ask a question that was very, very unique to your own situation, it may not get asked right away in this session because we're trying to cover as many questions that are broad-based as possible. And then we're going to do a round robin with these questions. So each doctor will take a turn to answer some questions. They'll say the question and then they'll answer it. And again, you know, please let us get through this and through the questions that we have on here. And then if we have time, we'll try to do any follow-up questions in the audience. Okay, thank you.
Okay, I guess I'm on the right side, and I'll start. There are a lot of questions, and we'll hustle, so we'll try to answer quickly. There's a question here: any research on prevention of colon cancer recurrence? And there is. It's hard to do research like that, but there is research other than chemotherapy. A couple of interesting things have been learned in clinical trials, where the clinical trials largely ask one chemotherapy versus another. But gathered a lot of information on personal habits to see if that made a difference. And it turns out that any of you who go to In-N-Out Burger, not a good thing if you've had colon cancer, because the Western diet, loosely described, and this is information that patients recall from on a questionnaire, that a Western diet is patients with stage 3 colon cancer are less likely to be cured if they eat a Western diet. So you might want to go out and get a walk. Patients who exercise have a greater likelihood of survival than those who don't. And even the amount of exercise, riding a lawnmower is not the same exercise as pushing the lawnmower. And patients who take aspirin also have a better survival with stage 3 colon cancer. Now, we don't really understand exactly why some of these work like that, and one of the possibilities is that people who are diagnosed with colon cancer may have already done those things beforehand and had a better prognosis because their cancer was less likely to recur because of those habits. But the bottom line is that there is evidence that those things help. And the other thing that obviously we can all but eliminate recurrence of colon cancer in a colon cancer survivor by doing colonoscopy. So clearly you're at lifetime risk for colon cancer, and that's the other intervention that works.
I do have a meeting at 12 o'clock, so I'm just going to step away. I have to catch a flight. So to start with, as a question, please explain why radiation therapy is recommended for colorectal cancer. I guess I didn't make it explicit in my talk.
Louder.
So when radiation therapy is recommended for colorectal cancer, so for primary tumor, colon cancer generally is treated with surgery alone. Radiation hasn't shown improvement upon surgery, meaning because it's hard to pinpoint after the surgery where the at-risk area is. But for rectal cancer, the standard treatment, recommended treatment for locally advanced rectal cancer will be before the surgery, chemoradiation to the pelvic region, including the primary and lymph nodes, and followed by surgery. So that's for the primary. And as far as for metastasis, as Dr. Cullen said, it's still being worked out. Chemotherapy is the prerequisite for patients who have systemic disease like metastasis. But focal therapy to target any gross tumor that's left after chemotherapy, radiation has a role, especially with radiosurgery techniques, and it's still being worked out. But usually we want limited disease, 1 to 3. The smaller and the more limited is better, because when you have more widespread disease, that means there are cancer cells we're not seeing. So treating individual tumor is not going to make an impact for the overall for the patient. Okay,
so I'm going to answer kind of two questions together. There were a number of questions just about bowel function, which I definitely spoke about after doing a sphincter sparing procedure for rectal cancer. And as I alluded to, I'm not always doing anyone any favors when I am able to spare the sphincter and avoid a colostomy, because bowel function can be very problematic. And a couple of people ask, what's disorder of defecation? That just means difficulty with pooping, okay? We all understand that. And a lot of different things can happen. So people will either have, looser stools or variable stools. Maybe the first one's hard, the second one is loose, or it progresses, or someone will evacuate stool and 10 minutes later feel like they have to do it again, and then they go back multiple times. That's what clustering is called. So meaning, instead of just going and having one bowel movement and evacuating the whole thing, it takes like an hour because of multiple trips to the bathroom to get everything out. Someone also asked just what kind of diet is best for low anterior. There's no particular diet. We give a lot of suggestions. Usually what we recommend is higher fiber diet, so things that will help bulk up the stool. Also just adding a fiber supplement, sometimes even using anti-diarrheal medicines like Lomotil or Imodium, so things that can help you not only package the stool but then slow it down. And then, I think a little bit of the diet is individual. So we often will tell people keep a diet diary, see what happens,
if you, every time you eat pizza, you're in the bathroom all night, well, maybe you can't have pizza anymore. You know, some people say, I don't care, I'm gonna have pizza anyway. That is your prerogative. So we don't have any set things, but that kind of idea, fiber, sometimes also more of the brat diet type things, if you know about that, bread, rice, pasta, applesauce, you know, so blander foods tend to be easier to tolerate. And then I love this question because people ask me this all the time in the office, which is that, is anyone looking at like small or large intestinal transplant? And there is issues with small bowel transplant because people actually will have to have that because of multiple resections, because you need your small intestine to absorb nutrients, but your colon is the easiest thing to live without, and it's not worth transplanting. So even though you think, oh, I'll have better function, if you replace with a new colon, it probably wouldn't work well anyway. So let you go ahead.
Thanks, Mika. I like pizza. I have a number of questions here that are sort of related, so we'll try to do that. Is this microphone on, or did I just talk real loud? Okay, good. Can you ablate without open surgery? The answer to that unequivocally is yes. You can do this percutaneously in the CT scanner without making any incisions other than the 2 millimeter puncture to put a probe in. Is ablation less effective than resection, and how do you decide whether to resect or ablate? I think until proven otherwise, we have to really rely on evidence-based medicine. There are really well-established situations to do conventional liver resections, and if you were a candidate for a conventional liver resection with metastatic liver disease, I would think that would be the course which would be recommended by your managing physician to pursue. That being said, it's unknown in certain circumstances. For instance, for very small hepatocellular carcinomas, there's been a couple of studies, one of which touted to be a prospective randomized controlled trial that said if you had a very selected single primary hepatocellular carcinoma, you did just as well with regard to survival with resection as ablation. That's a totally different thing than metastatic disease. And the studies are not out there yet that would allow anyone to say, oh yes, ablation is as effective as surgery. And until it is proven with scientific methodology, I think you would have to assume that the traditional alternative would be superior. That being said, there are patients who are not candidates for surgical resection or have undergone a surgical resection, and those patients certainly still can have percutaneous ablation as an adjunctive procedure to the traditional therapeutic methods. Back to you, Helen.
Okay, thanks. So there are 3 questions about other therapies that I'll tackle. Has it been shown or proven that HIPEC, that's heated intraperitoneal chemotherapy, HIPEC, treatment gives significant improvement to patients with colorectal cancer that has metastasized to the abdominal area? Short answer, no. It is clear that some patients benefit. This is patients with cancer in the connective tissue in the abdomen. Open the abdomen, pick out as much cancer as you can, and bathe the abdomen with heated chemotherapy. It's a procedure done by half a dozen or a dozen surgeons around the country, all offspring of somebody named Sugarbaker in Washington, D.C. It's only really, it does help some patients, and his results are very good, but he's ultra-selective about who to treat. And in terms of proof, there is no proof that patients benefit. Many people believe that the surgery is the key component and that the heated intraperitoneal chemotherapy doesn't add very much. But we don't really know, and it's never been adequately studied. About twice a year, I'll send a patient to a surgeon for that procedure. In my view, that's how often it's indicated. People may disagree on when to do it. If you're interested, there's a very good surgeon at UC San Diego named Andy Lowy, who's actually extremely thoughtful and careful. One of the main issues is if you've had multiple abdominal surgeries, it really is very hard to do because of scar tissue and other potential complications. Another question, you'd like to hear about adenocarcinoma vaccine treatment. So would I. It's been extremely disappointing. Cancer vaccines have generally not been successful almost across the board. And unfortunately, in adenocarcinoma vaccines for colon cancer have not been successful. They're generally tried in advanced disease patients. Perhaps those patients have defective immune systems already, and it's unrealistic to expect the therapies to work. But so far there really is nothing great, although it's being studied. And then what about hepatic chemoembolization or pumps to feed the liver? We actually had a very vibrant program in chemotherapy into the liver for years, but in general, while there may be an exception, the new treatments that treat the whole body are so much better than what we used to have. While we haven't abandoned it, we do it very, very infrequently. So there's still an occasional time where we would do that, but on average, that's not something we do. A few of you in the audience may be here because of that therapy and its effect on helping to cure patients with liver metastases. But in the current year, we think the new therapies are even more effective.
Okay. Next set of questions I'm going to answer about side effects. What are the long-term side effects of radiation on the pelvic area? And then there's another question about sexual function after radiation. So treating the pelvic area with radiation does have effects, and basically radiation causes scar tissue. That's what I tell my patients. So there are short-term effects of radiation during the treatment, which are usually self-limited. So you can have diarrhea, and you can have urinary frequency and urgency, and rectal urgency, and it does affect the bone marrow if a significant amount of the pelvic bone are treated. As far as long-term effects, that's what we worry about. Most patients actually do not have significant problems, like they really don't notice any side effects, but there are patients who can have chronic diarrhea, for instance, and also they can have rectal urgency, and the problem with defecation, like Dr. Varma talked about. Some of it is related to surgery, some of the radiation probably exacerbate that also. And as far as sexual function, it's well studied in prostate cancer. When we give much higher dose to prostate area, and it does cause radiation is associated with sexual dysfunction. And there are different theories. Some people say it's the neurovascular bundle, which is affected by doing prostate surgery. And then there's also vascular effect, which is more probably from the radiation. The rectal cancer, when we treat to the pelvic area, the dose is a little lower, so it's not well studied, and it's probably hard to separate out from what's the effect of surgery. And it, because the dose is lower, the effect will be less compared to prostate cancer. But I can't really quote you specific numbers on that.
Maybe I'll just jump in on that aspect of it, because I also received some questions about just kind of the pelvic function. Someone asked, what replaces the space left from the rectum? And that's actually a great question, because when you think about the pelvis, everything is really related. So the bladder, and then for women, the vagina and the rectum, they're all spaces that fill the pelvis. And so, when you take something out, there is a space there. Amazingly, the organs just kind of move around and kind of lie in their place. Some of the small intestine sometimes, which lives more higher up in the abdomen, kind of falls into that area. So the body just kind of fixes that up. There is some issue though. I think the vagina tends to tilt backwards, so as many women will complain of kind of retaining secretions, particularly after intercourse, that dumps later. And so there's some changes in the anatomy of the pelvis. And I think also, I was going to say, we as the surgeons, we like to blame the radiation for the sexual dysfunction, and then they blame us for the stuff, right? So
we have nothing to do with it.
So I definitely think
make
that
people depressed.
So it's clearly a combination, and there are some actually fairly good studies looking at the sexual function in patients who were involved in some of the important clinical trials for neoadjuvant chemoradiation therapy for rectal cancer, like from the Netherlands, for instance, where they examined the sexual function, and up to 35% of people, had some level of sexual dysfunction. I kind of alluded to that in my talk, and unfortunately, I think one of the main problems is that, in men, it's very easy to quote an impotence rate or erectile dysfunction rate, but what do you tell a woman? We don't know exactly what the nature of some of the sexual dysfunctions are. I mean, there are qualitative things, but we don't have like an objective thing. So that's an area of research that actually has really taken off, I would say, more recently. People are really, including myself, very interested in the quality of life associated with these treatments. I'm actually doing a study now, particularly looking at bowel, sexual, and urinary dysfunction in people who have their rectums removed for benign diseases, particularly because I want to really look at that role of surgery in that function. I don't want the radiation to confound it, but maybe after that we'll be able to look at rectal cancer patients too. So that's definitely an issue that I think I've seen in patients, affecting sexual function. I think, that radiation burn on the skin that leads to scarring, that also affects patients. And I think that one of the nice things is that by doing the radiation before surgery, we, at least for the bowel function, we then at least bring down the non-radiated bowel to work. So, and for whatever, there are reasons when some patients will have resections and then have the radiation after. I think that tends to, lend to worse bowel function.
Thanks, Mika. My next question is, would chemoembolization be an appropriate additional treatment to chemotherapy with multiple tumors in the liver? In general, we try to do this in a somewhat organized fashion, and the patient's placed on a systemic regimen. If that regimen fails, then alternative treatments are considered. And if someone failed chemotherapy, until we have more research on the irinotecan-B, I would say that the more appropriate consideration would be to do radioembolization with surspheres, which has worked at least anecdotally in these cohort reports which have been written as a potential alternative to patients who have failed the systemic chemotherapy regimen. But again, you have to understand, when you're doing the liver, you're just treating the liver. And one of the advantages of systemic chemotherapy is it's treating throughout your entire body, and if it's having an effect on the metastatic lesions, you can expect it would have it in addition to the liver in places where you may not even know that you have metastases. And I'll run into this next question, which is, what about interventional radiology for lung metastases? And clearly, Mika didn't get a chance to talk about it. If someone had a limited number of lung metastases, certainly they could be resected, but certainly people are also using the radiofrequency ablation, in some centers cryoablation, to treat a limited number of lung metastases, again with the advantage that it doesn't cause, does not require an open thoracotomy, and is generally less painful and can actually be done under conscious sedation. With that, I would also say there has not been prospective randomized controlled trials to compare the effectiveness of either surgery compared to cryoablation or radiofrequency ablation with regard to survival. So we just don't know the answer to that question at this point.
Okay, I've got a bunch of chemotherapy-related questions, so I'll take them mostly about oxaliplatin, which is the commonest, most frequently used treatment.
Excuse me.
Yes.
Could you just put the microphone
Sure.
in?
I'm sorry.
Each one of you.
Usually I talk too loud, but so does the tickling in your feet and hands go away? That's from oxaliplatin. 80% of the time it does go away, but that means that 20% of the time it doesn't go away. Most patients, it diminishes from its peak level, although a very interesting observation is after anesthesia. So let's say we do Folfox in a patient who's had a diversion of their bowel, and I send them to Dr. Varma for a hookup of the bowel. Interestingly enough, many patients, if not most patients, get a worsening of their neuropathy after anesthesia. It's not understood why. And that doesn't mean you don't do the surgery, but it's something to be aware of. The key to the tickling, which is, I rarely heard it called tickling, usually it's a little more noxious, is avoiding it. And we'll talk about avoiding that in a second. So that's oxali. What about chemobrain? Chemobrain exists. There's no question about it. Study after study has demonstrated, you take an accountant, for example, after a course of chemotherapy, they're just not as facile doing calculations in their head. This is unequivocally something that exists. It's much more of an issue in children, in young kids whose brains are developing, than in adults, but it does exist, both fogginess and sort of imprecision. And a lot of research here at UCSF, there's a symptom management group that's really national leaders in answering or looking at these questions. There is no way of preventing chemobrain. So again, a problem that we don't quite understand. How about mucus problems? I assume that's mucus from the rectum, and I'll let Dr. Varma take that. Numbness, altered taste from chemotherapy may persist for a long time. Metallic taste, very common, and that's got to do, oxaliplatin damages all the nerves in the body, potentially. So you can be constipated because your intestines don't work normally. You can get hoarse because your larynx doesn't work normally. You can have weird tastes. All of these travel with oxaliplatin. How can I get treatment in UCSF? Just come up, you grab me afterwards. Or if you need an appointment, 353-9888. Or vinook@cc.ucsf.edu. Another oxaliplatin question, oxaliplatin shock, permanently eliminating that drug. Oxaliplatin is very frequently associated with an allergic reaction, usually after 7 or 8 doses. And you get hot and bothered during the infusion, you turn red, you get a fever. In patients where we think it's very important to use the drug, it's working very effectively, and we think it makes a big difference in getting extra doses in, we have a protocol here where we desensitize patients by altering the time course of administration. So it is doable, but certainly there's a danger that you can die of shock from oxaliplatin. That's a real hassle for the doctors.
This is the test of the overhead paging system. Once again, the test of the overhead paging system.
In most patients, we don't revisit it because of the risks associated with it. Can you go back on FOLFOX if the cancer comes back? Well, you can, although almost certainly you'll develop neuropathy right away. Here at UCSF, our first choice for most patients with chemotherapy is not FOLFOX, but it's FOLFIRI. They're absolutely equivalent. And the reason that I do make that decision, usually with patients, is that after 7 or 8 doses of oxaliplatin, almost every patient will develop neuropathy. And the more oxaliplatin, the worse the neuropathy. So FOLFIRI, on the other hand, seems to be equally effective and doesn't cause neuropathy. So the problem with going back on oxaliplatin is the neuropathy will come back and you'll be limited in the ability to use the oxaliplatin. So you theoretically could, but we don't often do it. Let's see, another neuropathy question. How can you decrease it? Well, you can decrease it by using calcium and magnesium while you infuse the chemotherapy. It's got to do with the mechanism of the toxicity. We worried for years that calcium and magnesium might diminish the effect of oxaliplatin, but it does not. One thing that I'm reminded of is cold sensitivity. And every month I get a call from an emergency room that a patient who got oxaliplatin is in there with trouble breathing or hoarseness. This is a classic cold-induced problem from oxaliplatin. It's a nuisance. It's not dangerous. It really is sort of sensation rather than an active problem. How long can you use chemotherapy to treat chronic colorectal cancer? Well, it's as long as the body can withstand it and the cancer doesn't become resistant. Oxaliplatin you really cannot use for very long. The other chemotherapies you can often use for a long time, and we often use it at increasing time intervals. In fact, one of the things we know very clearly is that vacations, holidays are okay for most patients with colon cancer. So you don't need to be treated every other week like clockwork. Patients will do very well and may do better if they take a holiday for treatment. 2 more related to chemotherapy. Is there withdrawal after long-term use of Ativan? Yes. That's a problem. And that's something to work out with your oncologist. And patients, this is a different question. I'll get to this later, so I'll pass it on.
All right, I'm going to answer the rest of my question that I have to leave. Can radiation kill off decreased lymph nodes? yes, especially with radiosurgery like CyberKnife, we can give high enough dose to sterilize the lymph node. But when do you consider radiation? That's kind of more complicated question. Every patient is different, every case is different. But so when it's spread to the lymph nodes, potentially there's more disease. So chemotherapy definitely is indicated. Radiation can be used for like localized disease after chemotherapy, for example. So how small metastasis in the lung can CyberKnife treat? Basically, the smaller the better. As long as we can see it, we'll be able to target. And how many different sites? That also varies depending on the patient. We talk about we want to have limited metastasis instead of widespread metastasis. So would CyberKnife work for multiple sub-centimeter metastasis in the lung? Potentially, it's possible, but it's really individual patient-based. I treated patients with multiple lung metastasis at different settings. Usually, we treat one lung metastasis. There's no significant side effects. When we combine a 2 or 3, when we add up more, the dose of the lung does add up. The lung is relatively sensitive, so we have to limit how many we can treat at the one setting. But doesn't mean we can come back and treat more lesions, for instance. But really, it depends on the patient, how aggressive the tumor is progressing, and how the patient has been responding to chemotherapy. Success of Gamma Knife. So Gamma Knife is very successful in treating brain metastasis and other tumors, and also there's a size limitation. Usually we see less than 2.5 to 3 centimeter. Generally, the local control, meaning stopping the tumor from growing, will be 90%. That's what we aim for. We want 90% success treating the individual tumor. But for brain metastasis, when we treat one spot, you could grow other spots, and you could have Gamma Knife again, but we don't prevent other spots from appearing. So that's the Gamma Knife. And then is IRT only used during surgery? Yes, it's intraoperative, so only used in surgery. When using IRT, does the surgery need to be open or laparoscopic? Yes. You saw the size of the cone. We have to fit the cone into the tumor bed, so it needs to be open, and we cannot do it laparoscopically. So that's all my questions. Thank you.
I would just add about the IORT, because as someone who does a fair amount of that, it's usually in a patient who's had a recurrence, so it's usually not the first line treatment, and so oftentimes just to do the adequate resection, which may involve other organs, it's usually an open surgery anyway, so it doesn't even really come up that it's laparoscopic. Just along those same lines, someone asked, if after initial surgery there are positive, the surgeon did not get clear margins, is there any role for then coming to see a colorectal surgeon to get surgery? And are there any benefits? I think that once the surgery has been performed, the residual tumor that might be there, it has more to do with, is there gross tumor left? Meaning, could the cancer not be removed because it was involving other organs that can't be removed, or maybe an important blood vessel? Or is it that the tumor was removed with a feeling that all of it was removed, and then on the pathology there was evidence of microscopic positive margins? And that's kind of a different issue, and of course we deal with that all the time with Dr. Vanook. I think that if there is nothing that's visible that can be seen, there really isn't a role for going back and trying to do surgery. And that's when we discuss with Dr. Vanook about doing additional therapy, and then obviously close surveillance, looking for signs of any regrowth. If there is obvious tumor left, I get a fair amount of referrals for either people who had an attempted surgery, let's say, and then because of its involvement with other organs, nothing was done. We may also give chemotherapy or radiation beforehand, and then I would do a second surgery to go back and try to do a resection, kind of knowing that maybe if that tumor, let's say, involved the bladder, I'm going to get my urology colleagues involved, and we're going to do a resection of both. Or it's involving the tailbone, let's say, and I'm going to remove the tailbone. So that's all planned. We would do that then with the addition of the therapy. With the microscopic margins, we wouldn't go back and do an automatic resection. We would just give adjuvant therapy, and then we would, see if there's a recurrence. Someone else asked about if, let's say, there's recurrence only in the lymph nodes. This was specific to chest, abdomen, neck, but not in an organ. Then would any organ be removed? And I think that when you're talking about, and this is after 2 months, 24 months of FOLFOX and FOLFIRI, I think that if you have multiple nodal areas that are positive, we wouldn't then surgically go and remove them unless, you know, there was just like, let's say, one spot that could be removed and we think we can make the patient free of disease. I don't know if you want to add anything to that. I mean, usually it would be maybe changing the regime of chemo or continued follow.
Right. So this is this is where it's hard to practice in front of 100 people. It's very dependent on the details of the case, the time, the distribution, so it's hard to say. I mean, what we do at here is we see patients in combination with our surgical colleagues to really decide what's realistic and what isn't. It is the case that there are surgeons who will take 15 lung tumors out of a patient, and the argument against that is, what about the other 15 that they didn't see? And so there are any number of things that can be done. It's a matter of what is beneficial and what not. So it's very much dependent on the individual patient. I would say, though, that one of the real paradigm shifts is delaying surgery and doing chemotherapy or chemotherapy and radiation first. And that is clearly a big paradigm shift. One of the patients here in the audience participating in a research trial where we're delaying surgery for rectal cancer and giving more chemotherapy. And we actually have evidence that we're clearing out the cancer more efficiently by doing that, as opposed to immediately doing surgery, which of course is a reflexive plan. So one thing to say is, if a patient diagnosed with colon or rectal cancer on a Monday doesn't need, unless they're blocked, unless they're obstructed, doesn't need surgery on Friday. They need to figure out what the next step is, get their ducks in a row, because you can't put the toothpaste back in the tube in some of these circumstances. So again, a lot of different ways of doing it, and that's why, I mean, frankly, you look to go to people with expertise who communicate one with the other to make the best plan. Dr. Varma and I, for example, just saw a patient with rectal cancer and a single liver metastasis, and we communicate with one another. We get a plan together before we start the ball rolling, and then we're all on the same page. It's helpful, of course, for patients to get a consistent message, but mostly for us to have thought through all the possibilities and to come up with what we think. The idea is being strategic with the goal of curing the patient, and better to make the right move than to just make the first move.
Yeah.
In that regard, I also have a follow-up question on who decides in the treatment to do hepatic chemoembolization, etc. The interventional radiologist, the surgeon, the oncologist, and as Alan just said, you know, these are team decisions. And I think that if you're working in a center where the doctors have a high level of communication, then all of those sort of individual decisions can be eradicated. Because I think that more brains working on a single patient is appropriate. And one person may not know the limits or the problems involved in certain form of therapy, and that's what the strength, I think, particularly of this medical center is, that we have multidisciplinary conferences where everyone does work together and give their opinion on the appropriateness of the therapy where they may be expertise. There's another question that's actually I didn't even discuss, is what's the success rate of portal vein embolization? And portal vein embolization is something that we do in interventional radiology. It's a fairly specialized procedure, and it's generally done for people with a specific liver anatomy where they have many metastases, or a reasonable number of metastases in the right lobe of the liver, and a right hepatic lobectomy is being considered, but the left lobe is too small to take out the entire right lobe. In that circumstance, we do this procedure called portal vein embolization, where we block up all of the portal vein fluid on one side of the liver, which directs a substance called hepatocyte growth factor to the lobe which has not been embolized and causes it to grow. It actually has a fairly high degree of success, probably 75 to 80% in patients without underlying cirrhosis. But it is amazing how much liver you can take out, and it's only a very small percentage of patients prior to hepatic resection that require this procedure, but in selected groups of patients it appears to be beneficial, and it does have a reasonably high degree of success. Helen?
And I would emphasize that by working as a team, we think we make wiser decisions. One thing, just for a little advertising, there are national metrics for how patients do with given cancers, and national metrics for compliance with the guidelines that are universally accepted as standard. Who should get adjuvant therapy for stage 3 disease, for stage 2 disease, a number of different parameters. And here at the Cancer Center, actually, the colorectal group won the award this year for the best compliance. We were 100% compliant. Now, since I wrote the guidelines, I would think we should be compliant. but the other very interesting thing that we haven't actually figured out, and one of Dr. Varma's colleagues, a surgeon who's very interested in outcomes, is it appears that the patients with stage 3 colon and rectal cancer who are cared for here at UCSF do appreciably better, are likelier to be cured by a high percentage than those at other centers around the country. Now, it's hard to understand why that is. There may be many possible explanations, but I think it reinforces what we believe to be the value of seeing doctors who work one with the other and collaborate, because it really does, I think, make a difference, as many of you might have found. Okay, enough. That's the end of the infomercial. Can chemotherapy treatment and radiation from CT scans predispose someone to other cancers? Very good question. The chemotherapy from colon cancer, to the best we know, does not cause secondary cancer. So there are undoubtedly people who've had 5FU or FOLFOX or FOLFIRI who then develop leukemia, but it's rare enough that it's not believed to be cause and effect. Radiation can predispose to secondary cancers many years later, so that is a small possibility. What about CT scans? That's a very good question, and in fact, we believe that now, while we do scans following curative surgery and chemotherapy for patients with colon cancer who are survivors, we now believe we need to back off after 3 years or so, where the likelihood of recurrence goes diminished. And we do believe that there may be some cumulative risk of radiation. Of course, may not be any greater than sitting in front of your plasma screen TV, but it is a very good question and something that we're concerned about, although we don't really have the data yet. I mentioned that the rate of incidence of colon cancer has decreased because of colon cancer screenings, which is of course fantastic. However, does this trend is this reflected in minority groups? Very good question. And there is a group here at UCSF and many around the country in what are called health disparities. And it is an unfortunate reality that socioeconomic status has a big influence on how patients do. Largely, it's felt because of access to care. Although in some circumstances, minority patients may have poorer results because their diseases are biologically different. That's been shown in prostate cancer for African Americans. So it's a very good question, and one that we all wish we could make go away, but it is a real problem, and some groups have not benefited, as have others. Is the 80% cure based on all 4 stages? No. So patients with stage 1 colon cancer, which is really a polyp, those patients have about a 96% likelihood of not dying of colon cancer, but they have a 4% chance they will. Stage 2 patients, which is cancer that invades through the wall of the intestine but doesn't involve lymph nodes, is about 80% cured. Stage 3 patients without chemotherapy is somewhere between 40 and 60% cured, but with chemotherapy goes to about 75%. In stage 4 patients with colon and rectal cancer, we think we cure about 20 to 25%. Some of you in the audience are in that category. Now, when do we use the C word? When do we use cure? It's a really good question. You're never home free, in truth, but at 5 years, we generally believe the likelihood of recurrence is small. In fact, for stage 3 or stage 2 cancer, after 3 years, the risk of recurrence is exceedingly low. And then finally, what are the advantages for chemo with patients with lymph node involvement? Well, again, many different issues in terms of specifics, but a patient with involved lymph nodes without chemotherapy has about a 40 to 50% chance of being cured. That goes to about 67 to 75% with chemotherapy. So it's a very big incremental benefit in node-positive patients.
I got a few questions just about complications of surgery, for instance, like bowel obstruction and adhesions, and whether or not laparoscopic surgery can help that. Certainly the idea is that with less manipulation of the intra-abdominal cavity, that we're creating less adhesions. And certainly our short-term experience, and remember now, I was just telling you that the whole role of laparoscopic surgery has just come about in this past decade, right? So we don't really have a lot of long-term data on how many people are really getting bowel obstructions. But it does seem that, for instance, if there's reoperative treatment, that those patients have less adhesions. Whether that translates into having less hospitalization for bowel obstruction or less surgeries is yet to be determined. So that answer is still out. But what we know about bowel obstructions in general is that about 10% of people, 10 to 15% of people will have a risk of a bowel obstruction over their lifetime if you've had abdominal surgery. So it's a fairly significant amount.
It says that Dr. Helen, that would be me, spoke about selectively killing the tumor by combining tumor techniques, cutting off the blood supply, injecting toxins. And my question is, what is the time it takes for the tumor to decrease in size versus rather killing its activity? Is it immediate or not? Nothing's truly immediate. The effect that you would get from either chemoembolization or radioembolization is over time. You wouldn't actually immediately following one of these techniques, there may be some reaction around the tumor, which on imaging could actually make it appear to be enlarging, particularly at the rims due to hyperemia. And the effect in the diminished size usually will take the course of weeks to months rather than days to weeks.
Okay, so what genetic testing should stage 4 colon cancer receive for optimal effective treatments of chemo drugs? Well, I talked about KRAS. That has to do with the drug Erbitux or Vectibix, which are the epidermal growth factor receptor inhibitors. And you shouldn't get either of those unless your tumor is KRAS wild type. That's a normal gene. It's called a wild type gene. How effective is it as a single agent? It causes a decrease in tumors in size of cancer in about 10% of patients. In combination with irinotecan, it shrinks tumors in about 20% of patients. But that, again, don't be misled by the numbers. It can shrink the tumors a lot and make a big difference in some patients. Now, I'm sure some of you know what the side effect of Erbitux and Vectibix is. It's acne, and it is not pleasant. And so some people really are terribly distraught by acne. Much of our approach is to make people be parts of society. We love it when we think it's great and important for kids, for example. If a patient is a colon cancer patient who teaches, go to school and teach kids. Make the kids see that you're not a zombie, that you can get chemotherapy and function. I think there are a lot of myths that keep people from pursuing the diagnosis of cancer because of their perception. So I think it's really important for cancer patients to be out and about and to be in the mainstream. You have bad acne, it may affect you. And so it's not just somebody who's vain who would be affected. Many people are affected. So that's the downside of Erbitux or Vectibix, but it can work spectacularly well. So again, if it works in 20% of patients, don't think of it as incremental. It can be dramatic in a patient where it works. What other genetic testing should be done? Well, it's evolving. So there are other genetic tests on stage 4 patients that may predict for the same drugs, Erbitux and Vectibix, something called BRAF, PI3 kinase P10. This is evolving. What is unproven and is largely entrepreneurial, that's a nice way of saying trying to get into your wallet, is chemosensitivity testing. That is absolutely unproven, and I wish it worked. It's when you get a bladder infection, you send the culture to the microbiology lab, and they figure out what antibiotic to use. It just has not been shown to work in most cancers, and this is the internet has perpetrated a hoax in getting people to have special biopsies for tumor tissue analysis, which so far at least just plain doesn't work. I believe me, maybe the technology will exist at some point, but it doesn't yet. How accurate is genetic testing? So the issue with genetic testing and screening is a very complex question. If looking for a mutation in a gene can be very perfectly accurate, because that can be, if you have enough tissue, that can be very reliable. But other genetic testing is not so precise. So looking for inherited risk of colon cancer, these tests are somewhat imperfect, but there are a battery of tests that you do. We have a fabulous genetic counseling and screening group here with incredible expertise in breast cancer and colorectal cancer, and I'm not saying that only because Dr. Varma's husband, Jonathan Turdeman, runs the colorectal program. It is really first rate. And the key is knowing how to interpret the results. The short message is that to know if genetic screening in a family is worthwhile, the patient with the cancer needs to have the genetic test first, because you need to see what the genetic abnormality is in the patient, and then look for that genetic abnormality in the family members. It can't work, it just is not at all effective to do it in the other direction. But much of genetic counseling, it's come a long way, and I think one of the most important things for colon cancer survivors or people living with colon cancer is to make sure your family members, your kids, are all screened and appropriately managed, because those are cases that can be prevented.
Or the parents, for that matter.
Absolutely.
Sometimes we see a lot of young people here with cancer, and their parents haven't had colon cancer. You know, we know that colonoscopy is really the only way that we can detect these polyps early.
Now that's an advertisement for her husband.
Yeah. Speaking of, someone also asked, like, is there any role for suppressing colon polyps? And I'm guessing that this question is directed towards sporadic polyps, which is what most people would have, as opposed to a polyposis syndrome. And really, there isn't really a lot of good data. There's some data showing that the use of aspirin or NSAIDs, Advil-type medications, may reduce the risk. But really, the only way to prevent colon cancer is to get colonoscopy and to have polyps removed. So that's really the key. Someone also asked, is resection or surgery the only treatment if you have carpet polyps? So certainly, if you have a polyposis syndrome, that really requires surgery because you cannot remove hundreds of polyps if that's the case. And a carpet type polyp, if it's very low down in the rectum and it's discrete, sometimes that can be removed through the anus, as I showed you that local excision. But otherwise, if it's extensive or extends up through a segment of the bowel, then radical resection is really the only way to treat that, because you can't remove the individual lesions. And since we know that cancer comes from polyps, you don't want to leave a cancer cell behind.
I have a question. It says, can radiofrequency ablation be done with a patient who's on chemotherapy? Again, we prefer, if we're applying one form of therapy, that therapy be completed prior to the application of another form of therapy. Chemotherapy sometimes, depending on its type, can cause immunosuppression, and it can also alter your bleeding profile. In those circumstances, we would avoid doing any type of percutaneous or surgical procedure because it would increase the risk of complications. However, if the patient has a lesion and it's decided by the team that would be the best way to proceed, they are not immunosuppressed and their bleeding parameters are normal and they're not on any other medication that would promote the chance of having a bleeding complication, would go ahead and do it. Then there's another question on how prevalent is the use of interventional radiology in the treatment of colorectal cancer. And I would say the techniques that we're talking about, radioembolization is not extremely common throughout the community, but certainly interventional radiologists and surgeons involved in percutaneous or laparoscopic radiofrequency ablation is relatively common. And my only comment would be I would again seek out a center that has a cooperative, team-oriented management style in the selection of therapies for these patients, because then I think you get the benefit of people with a lot of different skill sets and knowledge sets, and I think that improves the outcome, as Ellen was saying.
Okay, the last ones. There are some very individualized questions which I just really don't want to answer because I like practicing medicine from across the bay. It's just not appropriate. In all seriousness, if you'd like to see one of us, we're happy to see you as patients, but I just can't be speculating about specific management issues. But the questions the last question is, please discuss what screening options are available and the benefits and risks of each. That's a lecture in and of itself. The method that works by far the best is colonoscopy. It's not perfect, but it's close to perfect. Sigmoidoscopy, this is not exactly the right analogy, but it's somewhat like doing mammography on one breast. Sigmoidoscopy only looks at half of the colon. It used to be believed that if you didn't have a polyp in the end of the colon, then you didn't have polyps at the beginning. Not true, debunked. I think sigmoidoscopy is better than nothing, but not much better than nothing. And one of the fascinating things to me is that some care services around here still do sigmoidoscopy. And I tell every family member, every acquaintance, that when you turn 50, say you've got rectal bleeding, if there's any debate, so you can get a colonoscopy. It's beyond me why sigmoidoscopy is still done. Now, something that could replace colonoscopy potentially is virtual colonoscopy. That's CT scanning with reconstruction of the colon is not easily visualized on the average scan. It's a collapsible tube, and depending on how it's oriented in the body, you may or may not see something. Virtual colonoscopy is an improvement on that, and it was really largely moved forward by a radiologist here at UCSF, Judy Yee. The problem is there aren't many centers that do it. It's a lot of expertise for the radiologist, and it's not generalizable. And if you have an abnormality, you need a colonoscopy anyway.
And I would say the most important thing is you still have to do a bowel preparation, which is, as most of you know, the worst part of the colonoscopy. So if you're not avoiding, if you're not avoiding the bowel prep, then I think it's probably going to have its role more in generalized screening for people who are at no or low risk, because it can, show you a negative picture. But if you have a lesion that's less than a centimeter, it's not going to pick it up. And so if you're at higher risk, you probably should have someone who can see it and address the polyp at that time.
Right. The other screening, there are molecular studies on stool. There's fecal occult blood. There are some pros and cons to each of those, but really the definitive screening is colonoscopy. At what age should children of people with colorectal cancer have colonoscopies? Well, probably it depends on how many family members, a lot of moving parts, but if you have a familial syndrome, it should be 10 years before if you have a sibling, let's say an uncle had colon cancer at the age of 40, the offspring should have their screening at the age of 30, so move it 10 years ahead. But again, if there's a familial risk, it's best to be seen by people who really have the expertise, because there are many issues. And screening for colon cancer also amounts to screening for some other cancers. So people at risk for colon cancer may also be at risk for breast cancer, prostate cancer, intestinal cancer. And again, this is better done by the experts rather than by me. Let's see. I have no previous family history of colon cancer. What are the chances that my daughter or sister has it? And the answer is that the random 85% of cancers are not related to family, and the odds are, I believe, 1 in 8 people will, I think it's 1 in 8 will have pre-malignant or malignant disease. So it's stunningly common. And that's why, if we could only get colonoscopies done. One last question was, how quickly does a polyp turn into a cancer if you have a hereditary syndrome? And that's quickly. So the 3 to 8 year rule doesn't apply to familial cancers. If there's a family history, you need a colonoscopy at least every other year, every 3rd year. I would get it every week.
I would add that inflammatory bowel disease is another condition in which if you have that, you're also going to be predisposed. And if you have inflammation of your colon, it's harder for people to see a polyp or a cancer. And so that's another higher risk group.
And there's even a new entity that was described largely in Asia, which is the flat polyp, which is really frightening because that means we've been missing them. And one thing I didn't mention, you'll notice, was barium enema. It's gone the way of the Edsel. I mean, the barium enema is almost not used anymore and is not an adequate screening test. To some extent because radiologists don't know how to read them anymore or do them anymore.
We like to call it a shadow of reality.
I'm a radiologist and will accept the slight. It actually is an adequate examination. Your disease would really have to be fairly advanced. And, you know, Alan was commenting on virtual colonoscopy, and I agree that it is a very specialized procedure, but I don't think that we should ignore the fact, because it's been getting a lot of play, that CT scanning does carry with it a fair amount of radiation, and I think that has to be weighed into your decision of where you're being screened. I myself, as a radiologist, have colonoscopies, and you can take that for whatever that's worth. I have one last question: is there any similar work being done to shrink or kill rectal tumors with heat to avoid the necessity of doing radiation? You know, these focal therapies have been applied to prostate cancer fairly effectively, not so much doing radiofrequency ablation, but doing cryoablation targeted by MR. But unfortunately, the tumors which develop in the wall of the bowel are not appropriate for that type of destructive therapy. It would only create perforation and would make subsequent surgical therapy extremely difficult, so they're not used in that setting. That's my last question.
And those are mine. Again, I didn't mean to ignore people who ask specific questions, but this really isn't the right forum for that. I think that's it. And we're on time, so.
I want to thank the doctors that were here today, Dr. Diller, Dr. Helen, Dr. Ryan, and Dr. Cole, for taking the time out of their Saturday to speak with you. And because we're a little with the time, unfortunately we're not going to be able to do any questions in the audience. But if you do have any additional questions, the Colon Cancer Alliance, as well as Naomi, we can field some of those questions and see if we can get them to the doctors another time. And as Dr. Vanook has said, you know, these doctors are available to you if you would like to be seen by them as a patient and follow up and do any more questions. And then what we're going to do now is we are going to move from this room down to the cafeteria, which is in the basement, 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 to the cafeteria, which is in